87% of our COVID patients were associated with comorbidities. So we routinely screen them now on hospital admission. Ain Shams University Children's Hospital is a large tertiary hospital. Actually, it's 2 hospitals with a total of 350 beds divided between the hospitals. We have the new hospital, 17 ICU beds, 8 intermediate care, 40 ICU beds, 120 ward beds. In the old hospital, we have the emergency department, 60 beds, 11 ICU, and 12 NICU beds. Average number of patients attending the ER is 41,000 patients per year. The average number of patients attending specialized clinics is about 122,000 patients per year. Average number of admissions is 15 to 16,000 patients per year. And this is a huge number. We are a tertiary hospital with referral from all over the country. What we knew back then in the first wave, that the risk factors and severity in multiple centers, China and Italy, that it's mild, that children mostly are affected with mild disease and they don't have severe disease, and that the mortality is really very low. It was less than 0.01%. Yet we had to be prepared, because later on we discovered that acute COVID can be mild and severe with hospitalization, and there were complications like COVID-19 associated MESI, whether it's febrile or Kawasaki-like, and severe MESI. We were prepared with the isolation floor, floor 6, first case admitted 23rd of May, total capacity 15 beds, 6 ICU rooms, and the other is ward, 2 residents, 7 nursing staff, 2 assistant lecturers, and 2 lecturers, staying 14 days continuous in isolation, caring for our patient. So the COVID cases in 2020, 148 patients. The MESI cases were 64 patients, and the surge was really highest in June and July, with a decrease in the cases, and now we are having another surge of cases, around 10 cases till now. The characteristics of our patients: median age was 7 years, 11% with asymptomatic, because we did not generally admit asymptomatic cases except if they were associated with comorbidity or they needed to be under observation. Underlying chronic disease, 87%, 67% had pneumonia, 71% GI manifestation, 74% were lymphopenic, 100% feverish, conjunctivitis around 30%, and seizures in 15%. Now, the worldwide data this week, this is from the Cough Kit in the USA project, where they keep a registry, have told us that we have a huge surge in children this wave, and reaching about 2 million child, and the cumulative death in children and teens is around 227, and the severity and intensive care hospitalization is increasing. So we were prepared with wave 2, and we have an isolation ward in our field hospital away from the children's hospital, because the first wave had a huge impact on our ER visits and our inpatient services. So we wanted this wave that we have a separate place where we can care for our patients and not affect the hospital services in Children's Hospital Ain Shams. So we had a section in the field hospital Ain Shams University used for isolation of children, with 4 ICU beds, 6 ward beds, fully equipped, and with the residents and nursing and assistant lecture, and it is supervised by Professor Hanan Ibrahim and the ICU team. This is the impact that we have of the COVID on ER visits and hospital admissions in 2020. We had 5,000 cases. This is our average in Jan and Feb. They dropped hugely in April, May, June during the first wave, reaching around 1,500 cases. And we started getting our services back, and it is maintained and it's going up because the isolation is in another hospital. This is the impact also on the admissions, reaching lows during the first wave and increasing to our past numbers, giving the service to the majority of children that we can serve. This is the impact on the specialized clinic. Of course, there were a reduction in number of children attending specialized clinic, and this had a huge impact on the services, especially in oncology patients and in immunology patients and in surgical patients, because they needed the medical service. And now we are having increased rates. In second wave, there was a partial reduction, yet we are continuing to give our services. There were development of pathways for the patient, pathway for everything, for the triage, the room, how we segregate our patients, how we give them their service. If they're going to go to a radiology department, they have to have special pathway, especially if they are suspected. We do triaging, and accordingly, we segregate the cases. Positive confirmed cases are referred to the field hospital. All visitations is limited during the COVID-19 pandemic, and all visitors are not allowed to the facility, and we use a lot of alternatives like phone calls and Zoom meetings. Use administrative controls, new services, entrance for suspected cases, entrance for the exit of the patients, and providing the alternatives for interaction with our patients. We have daily consensus, and we have shifted to telemedicine, educations shifted online, remote consultation for outpatients was done in the first wave on WhatsApp, where a consultant or a lecturer were responsible for all the mild and isolation cases at home, up to 100 consultation per day, shift of services to telemedicine for follow-up in some specialized clinics. We had more than 50 Zoom meetings with consultants discussing our COVID cases, our multisystem inflammatory syndrome cases, 4 webinars with international figures about latest updates in COVID-19. We had, of course, impact on healthcare workers with positive COVID in around 25% of the residents and 40% of the nursing staff. And resource allocation, 30% allocated to PPEs, 50% in the maintenance of our equipments, the ventilators, and 20% allocated to the isolation floors. We had a scientific impact protocol development and update this protocol according to the needs and according to the situation in our country. We had the COVID protocol, which we discussed by the professors, and we have the MESI protocol, the multisystem inflammatory syndrome protocol in children, which was published in Global Pediatric Health only this week, thanks to our team headed by Professor Sana and Professor Mona. We had 5 publications to date from Children's Hospital regarding COVID-19 impact in cancer patients, in clinical research setting, in stroke patients. Till now, we have up to 5 publications. This is a flowchart for our healthcare workers when they get infected, when to return the work, so that we ensure that the service is continuing and ensuring that our healthcare and frontliners are safe. Key message, the COVID-19 is an epidemic that is unprecedented challenge for all the healthcare systems worldwide. Pediatricians need to know that children are affected, and we are seeing this more and more in these waves, mostly mild disease, yet severe disease and complications can occur. GI symptoms and fecal-oral transmissions are frequent. PPE, social distancing are the #1 preventive maneuvers for this epidemic, and still much is unknown in the pediatric population. I would like to thank my co-directors, Professor Shema Meher and Dr. Muhammad Omar, for their continuous support. I would like to thank Professor Mona Ganzouri for her continuous support, and Professor Mustafa Hudhud. I would like to thank our frontliners, resident, assistant lecturers, nurses, and administrative staff for their sincerity and for being up to the task at all levels, at all times. All our esteemed professors in our department who helped in the protocol developments and pathway developments and the scientific impact that we are having, the protocol development group and the Children's Hospital COVID task force. Thank you all for listening.
Thank you so much, Professor Dr. Yasmin. Actually, Yasmin and Professor Hanan, when the second wave started to begin, I told them I don't want this COVID in our hospital because I was afraid about our students and staff. So Professor Yasmin and Professor Hanan make a plan for a different pathway to take all the COVID patients and the suspected patients outside the hospital, and they did it very well. And at the wave before, the plan was working so much fruitfully and nice. And we have a lot of patients with MESI, and I think a lot of papers is going to be published very soon. Thank you, Professor Yasmin. And now we will have the second professor, Mirvat Gamal. Dr. Mervat Gamal is one of the eminent professors in the Pediatric Intensive Care Unit, and she is going to give us a talk about clinical pathway for the management of COVID-19 in our hospital. اتفضلي دكتورة ميرفت.
مساء الخير.
مساء الخير.
أشكرك دكتورة منى وأشكر my dear professors and thanks to the whole department members. We are just highlighting our clinical management pathways in the pediatrics hospital in Ain Shams University hospitals, and on behalf of the scientific committee of COVID-19 management team, I'm just highlighting our protocol, and we are going to speak on the last version of our protocol. Thanks to our eminent scientific committee headed and initiated by Professor Dr. Mustafa Al-Hudhud, and still continuing the challenge with the push of Dr. Mona El-Ganzouri, and with all our eminent professors sharing from the whole specialties to create ongoing protocols. And through lots of Zoom meetings, hours of phone calls, and hundreds of researches, all the team cooperated to create some important items to help the frontliners to move ahead while facing the pandemic. Regarding the case definition of COVID-19 in the pediatric age group, we just have to classify our patients either to be patients with non-COVID illness presented by whatever symptoms due to an identified other etiology with negative PCR, and they will manage and treat it accordingly. And the other group of patients who are the confirmed COVID, and we depend on either the presence of positive PCR or positive exposure with close household members or close relatives with suggestive symptoms. And this group of patients, we further classify them either to have an acute infection of COVID, either being asymptomatic or having respiratory upper or lower symptoms or gastrointestinal, neurological, or cardiac, or even cutaneous manifestations. Another group of concern among our patients are the group who are actually non-symptomatic for COVID infection, but presented with a positive PCR and have another comorbidity like renal, cardiopulmonary, hem-onc. And another group of patients which of great concern among pediatric age group up to teens and maybe up to 21 years old, they can manifest by a late response of COVID infection, which is the pediatric multisystem inflammatory syndrome, temporarily related to SARS-CoV-2. By its very well cluster of symptoms, having a fever, inflammatory markers, multi-organ involvement with rash, conjunctivitis, cardiac, neurological, GIT, or even respiratory manifestations. The pathology of COVID-19 presentation, whether as acute COVID or MESI, depends on the onset of the time course of infection. The early manifestations are mainly related to viral replication and invasion, maybe starting by non-specific flu-like manifestation, then localized to GIT or pulmonary manifestation late in the first week or after. And sometimes in some patients, the host inflammatory response flare and starting after 10 days or a little bit more to present a hyperinflammation and starting some sort of the cytokine storm with invasion and inflammation of multiple organs with the presentation of MESI or multi-inflammatory syndrome of children. In the first wave, we used to see the acute COVID presentation clearly, and we used to see the MESI clearly with few cases with overlapping symptoms between the acute infection and the multi-organ involvement. But starting to see patients in the current wave, which really have both the early invasion manifestation due to viral load with starting manifestation of other deep organ affection. We used to classify the disease of acute COVID according to severity in order to triage our patient and select who are going to be admitted and who are not going to be admitted. It's well known for all of us that the mild illness, like any other flu-like manifestation, systemic manifestations, with no definitive pulmonary manifestation or dyspnea. Patients with moderate illness maybe have a lower respiratory tract infection or pneumonia, manifest clinically, but without desaturation. And those with severe and critical illness either presented by desaturation or having an imaging manifestation of lung involvement more than 50%, or have a critical illness situation like organ failure or septic shock, all messy. We have started to admit all patients presented with positive PCR till they are turned negative following a governmental instructions, but actually we were overwhelmed and overbooked, and by the many gatherings, and we have reached a decision to admit only patients with moderate to severe or critical presentation, or patients with multi-system inflammatory syndrome, especially the moderate and severe risk according to our risk stratification. We admit as well patients with COVID with comorbidity, and when the comorbidity necessitating admission, apart from the degree or severity of acute COVID. We used to admit the messy patients with complications or adverse drug effects from our medical treatment. And we used to admit infants less than 1 year of age for fear of any other complications. According to our meetings and gatherings and the feedback from patients, we are yet confused about different categories of medications, whether to use antivirals, steroids, anticoagulants, IVIG, vitamins, supplements, others, and the coming are too many medications. And actually, we choose to plan our treatment protocol according to our resources and our clinical research and agreement and consensus agreements from our meetings. And logically, and after the results of the release of many researches, the early phase of infection, which is due to viremic phase and viral replication, we better depend on antivirals if available, if effective, or monoclonal antibodies if available, blocking antibodies, and going through a deep invasion of the pulmonary tissue or other tissue organ affection, antivirals plus corticosteroids, and considering other tools coming to the way. And when we are going or moving to the late onset manifestations, whether through the acute phase of COVID infection or later on after weeks, what's called messy, we are confronted by another options of treatment like steroids, interleukin inhibitors, with less emphasis on the use of the antiviral drugs. Let's talk specifically on the most famous medications, and we actually involve them in our protocols and modify them throughout our work and throughout modifying our next versions. We started to use azithromycin in the dose of 10 milligram per kg once per day, followed by 5 milligram for 10 days in the early exposure to our patients. But actually the recovery, the results of the recovery trials changed our practice a lot. It revealed actually there is no benefit from azithromycin in patients hospitalized with COVID-19. And today we are not arguing against a drug or defending a drug. We are just telling or highlighting our protocol and trying to find the evidence. Hydroxychloroquine, one of the early medications, and we use it in few patients, but we didn't continue to use it anymore. Because of safety issues, we couldn't follow all our patients by regular routine ECG, and soon after the recovery trials revealed no clinical benefit of use of hydroxychloroquine in patients, neither in hospital or outside the hospital. The new dilemma about the ivermectin, which is a well-known anti-helminthic medication used before in many viral illnesses. And the dilemma started when the FDA approved drug ivermectin to inhibit replication of SARS-CoV-2, but in vitro. And all researchers make effort to find the dose to be used and effective in vivo. Many protocols, either to pre-exposure or post-exposure or acute infection, but unfortunately, the panel assigned for COVID-19 guidelines protocols for the National Institute of Health following the WHO and CDC, they recommend against the use of ivermectin for treatment of COVID-19, except in a clinical trial. We actually used ivermectin in the first wave, and still we are discussing if we are going to use it in the next wave or what we are going to do with ivermectin. Remdesivir, and if I have a message for the treatment of acute COVID, is the introduction of the remdesivir to our protocol. Remdesivir is one of the actual direct antiviral medications, and after the recovery trial final report, which was released in November 2020, they found a significantly reduced time to recovery from acute illness when applying remdesivir, and even remdesivir alone as a sole antiviral medication. But this benefit was recorded when the patients were admitted and used supplemental oxygenation. Yani what does it mean? Their observation and conclusion that remdesivir has no observed difference in the time of recovery for mild to moderate illness without the need of oxygenation. يعني البيشنتس اللي كانوا presented بmild to moderate illness and no need for oxygenation, they didn't get any benefit from remdesivir. Another group of patients who are the mechanically ventilated patients or patients on ECMO, they didn't have a difference or a value for the use of remdesivir. But the only subgroup who presented a great effect in reduction of the time of recovery هو الجروب اللي كان moderate cases with oxygen needs, but not high flow oxygen needs. And the beneficial effect of remdesivir was best released or best noticed and observed when it is introduced in the first 10 days of illness. Remdesivir is a promising antiviral agent and has an approved dose for pediatric patients above 12 years and above 40 kilograms. And there is an experimental dose for those less than 12 years. And currently there is a randomized controlled trial testing the pharmacokinetics of remdesivir in pediatrics, not studying the efficacy, but studying the pharmacokinetics, depending on the results of the recovery trial, which proved the efficacy of remdesivir use in all ages, in spite of having few cases of children and pregnant women in the recovery trial. But the WHO and the NIH recommends the use of remdesivir in the selected group, which I have previously mentioned. Dexamethasone, which is a type of corticosteroids and a well-known anti-inflammatory medication from the early preliminary data of the recovery trial, supports the use of dexamethasone, low-dose dexamethasone, whether IV or oral. And this started to be introduced to our protocol. And the best results for dexamethasone, whether isolated or whether remdesivir, was if we are introducing dexamethasone for those patients with respiratory manifestations, not only by finding in the CT, but all if the patient has finding in the CT but is symptomatic and in needs for supplemental oxygen. To sum up, and we are following, trying to follow in our protocol the guidance of the National Institute of Health. It's better to use the monoclonal antibodies, which are not available in Egypt, but available abroad for the non-hospitalized mild to moderate COVID patients. And to start for the hospitalized patient, but does not need or require oxygen, not to give Dexa or antiviral unless it is a high risk group like malignant patient, patient with cardiopulmonary disease, etc. While patient to hospitalized patient and needing a regular oxygen supplementation, the best drug of choice is the remdesivir in the early 10 days of admission. We can give dexamethasone if remdesivir is not available, and we can give both remdesivir or dexamethasone. In hospitalized patients then required high flow oxygen or non-invasive ventilation, the effect will be better if we use dexamethasone or dexamethasone plus remdesivir. But remdesivir comes down in its efficacy if the patient were ventilated or on high flow oxygen. And if our patients are on mechanical ventilation or an ECMO, dexamethasone will be a drug of choice. This guideline applies for adults and as well for pediatrics. But still, researches and data from the pediatric age group are scarce compared to adults. But these drugs, whether remdesivir or dexamethasone, recorded side effects are well known and minimal in both adults and pediatrics. Another dilemma of the anticoagulant use, and I think we are قتلناه بحثا الموضوع ده في الريسيرش في البروتوكول بتاعنا. Actually, we started aggressive. We started to use full therapeutic doses of anticoagulant in the early phase of the first wave, sometimes for fear of D-dimers being high, and sometimes for fear of pulmonary involvement. But our clinical practice revealed some side effects of the high doses of anticoagulants, and we moved to a prophylactic dose of anticoagulant. And our protocol highlights the use of anticoagulant only for hospitalized COVID patient, not for outpatient or discharged patient. And we use the prophylactic dose of low molecular weight or fractionated heparin, preferable in the pediatric age group over the oral anticoagulant. There is no role of use of anticoagulation in non-hospitalized patient unless in this patient need the use of anticoagulant due to another pathology. And if the patient is deteriorating during his hospital admission, whether pulmonary or cardiac or neurological, or sudden loss of peripheral pulsation or development of thromboembolic disease as proved by imaging, we move to a therapeutic dose of anticoagulation. Vitamin C, vitamin D, and zinc are very nice and supplements, but there is no evidence with or against the use of them in COVID, whether acute or messy. And the WHO and National Institute of Health are recommending further studies, and the well-known recommendation is not to exceed the usual therapeutic doses. The other sector of our patient with the important, serious, and actually is a main concern in children is the multi-system inflammatory syndrome. And as previously mentioned, our protocol for MESI was just about to be published, and this is a nice move created and initiated by Professor Dr. Sana. We set the inclusion criteria of MESI, and it's well known to the all. The patients presented by fever lasting for 24 hours or more, with one or more of clinical manifestations, and a positive history of COVID-19 with a recent or previous, and it is not related to the severity of acute illness of the acute COVID in the same patient. And we don't know yet what are the risk factors which propose to push the patients to develop MESI or acute COVID or acute COVID followed by MESI. But most of our patients recorded in the first wave of COVID have minimal or no symptoms for the acute phase of infection and presented to us in the late phase of MESI. We further classify patients into a mild risk, a moderate risk, severe risk. And the mild risk, actually, there are few patients اللي هم جايين ب low grade fever, which generally they are well, and they discharged home upon examination with follow-up. The severe risk patients, those who were presented by toxic shock or a cardiac dysfunction from the start, and they were admitted for the PICU for shock management, vasopressor support, in addition to applying the protocol for MESI for the severe risk. The moderate cases, the moderate risk patients, they are having low-grade fever or high-grade fever with other symptoms of organ involvement, but they are hemodynamically stable and they are not showing severe cardiac or system involvement. Those patients were kept in the isolation ward if they are still PCR positive. في الأول كمان كنا بنعزلهم لو كان عندهم immunoglobulin IgA positive, but it seems that in the serology positive ما نقدرش نعتمد عليه ك equivalent لل PCR positive who can be admitted in the general ward if they are a PCR negative. The essential treatment of the MESI in many centers in the US, in the UK, and in our center is essentially dependent on steroids and intravenous immunoglobulins. We have used steroids in the form of solumedrol for the severe patient or shocked patient or the high-risk patient. We started by the use of pulse steroids in the usual dose for 3 days, then taper according to the protocol. In the moderate and the well-appearing mild risk, we use an oral dose or intravenous dose in the moderate risk of solumedrol in the usual dose of 2 milligram per kg, just for 5 days, and then withdraw the dose over 2 to 3 weeks with follow-up of the clinical response. Stress ulcer prophylaxis is a mandate because we have met a few of our cases, 2 or 3 patients get back to be admitted for a GI manifestation or GI bleeding. Intravenous immunoglobulins in the usual dose of 2 gram per kg per day was the mainstay line of treatment and received by all of our MESI patients. Sometimes we were discussing for the use of a second dose of immunoglobulin, but case by case. But still, the cost and the efficacy of immunoglobulins are not well balanced. The administration and the management actually was generous with us to make it available for all patients with MESI to receive an intravenous immunoglobulins and almost on the full dose of intravenous immunoglobulins. Interleukin inhibitors, they are a second or third line management in the MESI, whether they are interleukin 1 or interleukin 6. And the decision to initiate them were after failure of the other tools to treat the manifestation, the fever, the systemic involvement, and it is a case-by-case discussion of the committee and decision. But still, safety and efficacy are not well studied for the use of interleukin inhibitors, with the debate about them everywhere. In the case of MESI, we use aspirin and well, and we use actually started by therapeutic, but we shifted to a prophylactic dose soon after, regardless the level of the D dimer. And 2 to 3 days before discharge, we resume the patient to an oral low dose of aspirin and to stop Clexane, because no rule for subcutaneous anticoagulation or Clexane outside the hospital. And we use aspirin for the fear of development of any thrombosis or coronary dilatation for the patient with MESI. We discharge our patient whether acute COVID or MESI based upon protocol discharge criteria when they are well saturated, tolerating oral intake, hemodynamically stable, has no fever for the last 48 hours, improving and trending, improving inflammatory markers. No need to go to normal markers before discharge, but once we see the trending of the improvement of the inflammatory markers, we sometimes in the MESI تحديدا we use the low dose aspirin. We didn't discharge patient on Clexane, and they are advised to follow up in the emergency department. And there is some plans to have post-COVID outpatient clinic to follow up our patients. Thank you for attending the webinar, and foremost thanking Dr. Mustafa Al-Hodhod, Dr. Sana for always encouragement, and not only for the science but for the sincerity in work. Thanks to Dr. Mona for continuing encouraging us and motivating us to continue. Thank you for Yasmin. She is doing a very hard work. Yasmin, Shayma, Muhammad Omar. Thank you for our frontliners, the residents or assistant lecturer or lectures, and hopefully we are usually believing we can do something. Thank you.
Thank you so much, Professor Dr. Mervet. A very nice talk. But I have several comments يا ميرفت على التوكس بتاعتك. انت قلتي المايل تو مودريت تقريبا مش يعني ما بنديش حاجه، صح
Yes.
ولا لا؟ يعني
أيوة.
قلتي الريمديسيفير ده افكتيف بس في الناس اللي بتاخد اكسجين. طب المايل تو مودريت هنديهم بس انتي بايوتكس والسبلمنتس؟ انت في
هو
الجدول بتاعك
حضرتك لو هنتكلم المايل بيشنت اللي هم ما عندهمش اي necessity for hospital admission, they should have the usual currents of supports like fluids, rest.
طب مع azithromycin ولا
and the evidence is not to use or medications or anticoagulation or even overdose of
لا انا بتكلم على
vitamins.
azithromycin ياخدوه ولا لا؟
has no rule based on the recovery trial which is releasing
يعني هو بقى سمى فود وسبلمنتس وكده. طب الحاجه الثانيه بقى ان انا كنت قريت ان الريمديسيفير ده بيقلل الهوسبيتال ستي من 13 يوم ل 11 يوم. which is
بيقلل the duration of the recovery فعلا even from 15 to 10 days but in a certain special group of patients. If we choose the patient to be in oxygen need but not for mechanical ventilation or ECMO etc., it will be cost and effective.
انا مش بسال حاجه بس for the sake of discussion. انت جبتي سيره خالص اللاكتوفيرين فده out.
There is no evidence about lactoferrin or evidence in a large randomized controlled trials about lactoferrin in the guideline.
ده طلع من الموضوع لانه غالي ومفيش داعي نديه للناس. يعني لو
maybe later on نلاقي studies على الحاجات دي كلها. يعني هو اول ما الهيدروكسيكلوريكين خلاص لا طلع ملوش evidence، الريسيرشرز ابتدوا يدوروا في حاجات تانية. For the current being لحد ما بنتكلم دلوقتي مفيش evidence about the others who I didn't mention.
Okay, thank you so much, Professor Dr. Mervet. And we'll have the next speaker, Professor Dr. Hanan Ibrahim, Head of Pediatric Intensive Care Unit. She is my dear friend, Dr. Hanan. احنا بقالنا مع بعض I think Dr. Hanan 30 years. She's one of the best persons I had ever اتعاملت معاه in everything. يعني she is عندها ethics، عندها علم غزير. هي شايلة البوردن بتاعت الانتنسيف كير يونتس in all pediatric Ain Shams University Hospital, الأكاديمية القلب، الكوفيد الميداني، الاثنين intensive care units الموجودين في مستشفى الأطفال. She will give us a talk about what we learned from the first wave. اتفضلي دكتورة حنان.
شكرا استاذتي الغاليه الاستاذه الدكتوره منى الجنزوري. فعلا هي زماله عمري يا دكتوره منى، وربنا يديم علينا الخير والمحبه والعلم، وشكرا لحضرتك اني اتحت لنا الفرصه دي ان احنا نعرض مجهودنا غير خلال فتره الكوفيد 19. I will talk briefly about what did we learn from the first wave. We all know that SARS or COVID-19 till August, till the 10th of August 2020, the numbers are about 20 million infection and more than 700,000 deaths worldwide. هي الأرقام دي ارتفعت جدا جدا في الفترة الأخيرة. This is in the 3rd January. We reached up to 83 million cases and about 2 million deaths all over the world. The numbers from Africa is a little bit less than Americas and Europe. We know that the recording system in Africa may be a little bit not accurate, but this is what is written in the WHO website. What about the case fatality rate? Is it fatal disease or it is not a fatal disease? The case fatality rate, which is calculated by division of the number of cases over the number of diagnosed cases multiplied by 100. What is important to us as a pediatrician in the fatality rate among the children all over the world much less than adults, while elderly people much more than the adolescents. Yes, at the beginning of the first wave, we all have the impression that the COVID-19 is a disease for adults, but children still part of the story. We all know that it's milder and in children and it is less affected than adults, but why? There were many assumptions about why the disease affected adults more severely than children. وتحط assumptions كتير, a lot of theories like viral theory, for example. It's some sort of competition between the viruses that is present in the throat of the children and the COVID-19. The ACE receptor theory, which is the receptor through which the virus enters the body and it is less in concentration among the children, and the immune theory, because the immune systems of the infant and children is a little bit naive than the adult, and much more damage happening in the adult due to the war between the immune system and the virus. However, the first lesson that we learned from the first wave is that children can get COVID-19. And the documented, laboratory documented cases of children is about 13% of cases. Of course, it is less severe than adults, but children affected among COVID-19. The age distribution varies. From the young age, it's very little among the young age, it's about 7%, till after the age of 10 years through 18 years, it's about 34%. لكن لازم نعرف ان الهوسبيتال admission rate is much higher among infants less than 2 years عن الأكبر من كده. However, as we can see from the second wave, yes, children are more likely to be infected in the second wave than in the first wave. We don't know why, because the numbers are much high, or the percentage of the affection of the children are much high. We don't know till now. However, during the first wave, there is a second lesson that we learned during the first wave, that the children develop their own pattern of the disease. We have two phases or two phases of COVID-19, which is COVID-19 infection itself, and this started from late March to late May, and the messy, what we call messy, which is from early June to late August. Starting with acute COVID-19 in children, we can tell that the same manifestations that we can see in adults, we can see in children with a different frequency. For example, insomnia مثلا والanosmia مثلا, وإنه loss of taste or smell among children is much less than adults. But the respiratory manifestation represent more than 60% of the manifestation in children, like adults actually. Other manifestation like GIT manifestation, headache, abdominal pain, rhinorrhea, myalgia, sore throat, neurological manifestation is less than the respiratory manifestation. So Children mainly presented with respiratory manifestation, followed by mucoenteric manifestations in the form of gastroenteritis, appendicitis, enterocolitis. We have seen a lot of cases like this, and even sepsis and septic shock. Many children can come with COVID-19, documented COVID-19 with normal labs. We do not find lymphopenia, we do not find increased serum ferritin highly or CRP. This does not exclude COVID-19 infection among children. What about imaging? Less frequently affected than adults. 50 to 33 to 50% in some studies among children has no imaging finding at all, while 30% had ground glass appearing, 27% unilateral finding, and 23% bilateral finding. Lung ultrasound can help. We can see the subpleural consolidation and the confluent B line. This is described among Chinese children. أول ناس وصفوا إن الأطفال ممكن يجي لهم the same damage in the lung and the same CT finding like adults are the Chinese. This is the peripheral, as we see, subpleural consolidation, and here starting bronchiectasis changes. This is our patient, one of our patients. We can see through this video the damage that happened to the lung. Here, peripheral. We can see the right side completely damaged, and there is a lesion in the left side also. You can imagine this is 8 months old infant with severe lung damage. And this is the window view. We can see the consolidatory changes here. Another lesson we learned from the first wave, that chest X-ray has no role in the diagnosing of COVID pneumonia unless it is very late and the patient in the ICU. What about our own experience, our own presentation? We have seen a lot of patients. I think we reached now, Dr. Yasmin knows well, about 200 patients maybe, with median age 7 years, fever in 100% of cases, pneumonia 88, GIT manifestation 84, comorbidity 87, lymphopenia in 75%, not all patients were lymphopenic, neurological manifestations 17% in the form of encephalitis, edema, and stroke, DKA, firstly presented DKA with COVID-19, which means some sort of pancreatitis, and the first presentation was diabetic ketoacidosis, acute abdomen, and diagnosed as appendicitis, and even opened by surgery and proved to be COVID-19 infection, all were PCR positive. We can see that 17% out of the cases with COVID pneumonia needed ICU admission, and out of this 17%, 80% with comorbidities. What about the international numbers? Actually, the international number as regard ICU admission and critical illness was much more or less than our numbers. About 2% severe cases, 0.7% critical cases. وهنا هنقدر نشوف إن about more than 50%, 57% may be either asymptomatic or mild illness, and 39 are moderate. Maybe this is because this is from the whole population that got COVID-19 among the children. لكن احنا بنقول the percentage of critical ill patients among admitted patients in our hospital. What are the risk factors to develop severe disease? اللي يخلي طفل يجيله severe disease وطفل تاني يجيله mild or moderate disease? Actually, there are many assumptions. No one can tell which of which. Those assumptions include the following: obesity, medical complexity, severe genetic, neurologic, metabolic disease, hematologic disease, sickle cell anemia, congenital heart, diabetes, kidney injury, asthma if not controlled, and other chronic pulmonary diseases, immunosuppressive suppression due to malignancy or immune weak medications, if the patient is younger than 1 year. What about our own experience? I can tell you the severest cases that I have seen in my ICU are the diabetics. I don't know why the diabetics, when they got acute COVID infection and reach to the ICU, they are in a very bad shape. And I cannot tell you that the young age is a risk factor for the severe disease, but when the young infants younger than 6 months admitted in the ICU, the outcome was very poor actually. Causes of ICU admission, pneumonia on the top of the list, DKA and carditis, neurologic presentation, acute appendicitis, and septic shock. We followed our protocol, that we invented in the pediatric unit Ain Shams University, that already discussed by Professor Mirvat Gamal. I will give the lessons that we learned inside the ICU from the protocol. I will not repeat what she's already told us. We relied on the oxygen saturation less than 92% and the work of breathing. Both are the risk factors that make us to decide to give the patient non-invasive or invasive ventilation. Then we follow the patient, and following the FIU2 together with the work of breathing, we can decide, is it non-invasive or I have to intubate the patient? And if I have to intubate the patient, I have to follow the driving pressure. لو العيان احتاج driving pressure 15 فأكثر، ده معناه إن أنا هقدر أتحكم في التايدال فوليوم، أزودها وأقللها according to the needs. Then I have to take a look if the patient needed more than 70% by 2, so I have to raise the beep. If I have to raise the beep, I have to sedate my patient. Then, according to the lung compliance, I can take my decision: high frequency ventilation or regular ventilation. And we do not forget the prone positioning. The prone positioning was very important. So, non-invasive ventilation, I have to avoid non-invasive ventilation to avoid the spread of infection. But if I use it, please don't use nasal bronchs and use the face mask to avoid the infection. And this is a box that we use to intubate our patients. احنا عملناه يدويا هذا البوكس thanks to Professor Mirvat Gamal and Dr. Samuel. هم مشوا وراه لغايه ما قدرنا نعمل البوكسز دي ونستخدمها. Prone positioning is very important. انا يمكن بقول through my work in ICU over more than 30 years, the prone positioning wasn't that important except in COVID-19 pneumonia because of the present VQ mismatch. We can even use the prone positioning with non-invasive ventilation. We can use it from 12 to 18 hours per day, and we can use it all over the 24 hours early in the disease to save the patient or to avoid intubation if you want. This is about acute COVID infection. What about MIS-C, multi-system inflammatory syndrome in children? First described in late April in UK and USA. This is the inflammatory syndrome followed COVID infection that involve nearly the whole organs of the body with inflammation. It can be presented as a mild disease. It can be presented like Kawasaki disease. It can be presented with even a septic shock. We do not know the patient will be presented by which picture. This is the spectrum which is published by UpToDate from febrile illness, Kawasaki-like, or even shock patient. But I like the definition of our protocol, or you can choose WHO protocol or CDC protocol, whatever. It's a protocol of a febrile child in the era of COVID-19 presented with 2 of the following, like rash, hypotension, myocardial affection, evidence of coagulopathy, or acute GIT manifestations. Then we will do the markers, and the lab work will document the diagnosis of MIS-C. This is the age group affected by MIS-C. We can see here it affects older age, but yes, still infant can be affected. We have 1 neonate with MIS-C, and it is written in the literature 3 further case reports other than our case. So when you diagnose with suspected MIS-C, you have first to apply the case definition. So you diagnose MIS-C, then you have to do risk assessment. Is it mild, moderate, or severe? Then you have to do the workup for the MIS-C cases. This is the initial workup, which including the CBC, the ESR, the CRB, the D-dimer, BNB if available. We do not do the BNB, and the serology and the PCR of COVID-19. Then after admission, you can do the secondary lab work. Those are the cutoff values, the suggested cutoff values that we put it in our protocol. It will be available on PubMed very soon. And what are the characteristics of our MIS-C patient? The median age was 8 years, fever 100% of cases, GIT. هنا GIT manifestation 68%, و respiratory manifestations only 2%. على عكس البرزنتيشن وقت ما كان في acute COVID infection Cardiac involvement among admitted patients was very high, about 89%, neurological manifestation 70%, conjunctivitis 32%. We can see here the extensiveness of the rash among our patients. We can see this is the peeling هنا نقدر نشوفه in the hand of this young girl. This is another picture. You can see the mucous membrane affection also. This is the rash, vasculitic rash in another boy, mucous membrane affection and even ulceration. Okay, on the contrary of COVID-19 infection, messy cases, most of the messy cases admitted in the ICU, 70%. And on the contrary of COVID infection also, most of the messy patients were previously healthy. 73% were previously healthy. You can imagine a completely healthy child who got an illness, and within 5 days, he will be admitted in the ICU. It's a very serious and fatal disease, actually. What about the characteristics of our patients admitted in the ICU? All of them admitted with a mix of septic and cardiogenic shock, with a significant cardiac injury, with or without other organ injury like acute kidney injury, CNS manifestations, hematologic and hepatic manifestations. There is a wide spectrum of cardiac injury among messy cases involving myocarditis and left ventricular dysfunction, valve affection without or with left ventricular dysfunction, where pericardial effusion was very minimal. Coronary dilatation was a little bit not minimal, but less common than Kawasaki disease and tachyarrhythmia. We can see here, this is a dilated right coronary. You can see this is a dilated 4 chambers, and you can see this is a patient with left main coronary dilatation. It's very huge, near the size of the aorta. This patient was very young, I think, who was 2 or 3 months, something like this. We can see in this video hypokinesia. This was, I think, a girl, 11 years old girl. You can see the mitral regurg, significant mitral regurg. And I would like to thank Professor Niveen Mamdouh, who supplied me with these pictures and video. What about the ECG? The ECG is also important. We can see here, this is a complete heart block, a case of myocarditis, and we can see its ST segment changes here. When you face an ECG like this, it is exactly like adults with infarction. It's a thrombosis inside the coronary arteries. Another lesson that we learned during management of messy, it's a case of septic shock, but with some consideration. Consideration number 1, be cautious about fluids you give into this patient. Consideration number 2, most of the patients responded to norepinephrine and epinephrine with low or moderate dose. We didn't use the high dose. All patients improved by milrinone due to the cardiac element. All patients received our protocol, and do mechanical ventilation as early as you can if needed to decrease the load on the heart. This is the outcome of our patients. You can see most of our patients died due to comorbidity. I cannot tell this is due to COVID or messy, because all previously healthy messy patients who ventilated and even who needed high frequency ventilation, thanks God, survived. What about the second wave lesson? The second wave lesson, the children infection rate is higher than the first wave. Number 2, symptom overlap much more than the first wave. Today, I can see a patient with pure gastroenteritis. In the first wave, we assumed this is a strain with GIT, he will pass, it's okay. No, 2 or 3 days later, this patient developed pneumonia. So we cannot feel that safe or relaxed from this presentation. And the new surprise is that COVID infection and messy presentation overlap. Yes, in the second wave, we have seen a lot of cases with much overlap. The patient admitted with typical COVID pneumonia. Then after admission, he developed carditis, and even in some patients, he developed coronary dilatation with elevated inflammatory markers. This is why I want our resident to know this flow chart, this nice flow chart. You have the approach, you follow your protocol, but if you suspect cases and document it, then you use the protocol and you find something important, which is persistent fever, Kawasaki-like manifestation, shock during the same admission, For heart failure, please do two things. Number one, do the laboratory assessment for MESI. Number two, consult the cardiologist for the echo and ECG and the whole work of cardiac affection. And finally, what are the lessons that we learned from COVID? Lesson number one, children of all ages can get COVID. Number two, usual children get it mild, although severe cases reported. Number three, the second wave expected to show higher incidence. والله أعلم هنشوف فيها إيه تاني. Number four, MESI is not common but serious condition. Be alert of MESI. And finally, we have a duty to keep up to date with published literature so we can provide care. And please, any weird symptom you find in your patient, please during this week ابحث عن COVID-19. Thanks to the MESI committee, thanks to Professor Dr. Mona Ganzouri for allowing us to do this meeting, thanks to my PQ team. And in spite of all damages that they have among them and among their families, they are keep caring about their patients and following the whole ICU units, including that one in the field, Mustashfa Al-Medani. And I want to announce about this book. I like it. Children's story book released from the WHO. It helps children and young people to cope with COVID-19, and it's available in Arabic language. And اللهم اجعل قلوبنا راضية بما قضيت. Thank you.
Thank you, Professor Dr. Hanan. This is very nice, illustrative, practical talk. I really enjoy it. I have two comments. I would like to thank برضو التيم بتاع cardiology, Dr. Niveen Mamdouh and her team for doing all the cardiology workup of the MESI and the carditis patients. And I would like to tell you a comment. I noticed this wave. Most of the patients above 2 years are coming with severe gastroenteritis. Their PCR is negative, but I think these are COVID because if you leave them for 1 or 20 or 48 hours, they are shocked and they should take fluids and anti-diarrheal. If you combine them with antibiotics, they came with mild bronchitis. If left, they are going to develop bronchopneumonia. What's your opinion about this?
Yes, it's very remarkable. The attacks of gastroenteritis is very remarkable now.
Last month.
The main presentation, even in young adults. I have seen many cases like this.
Usually we used to have this gastroenteritis by this time of the year with rotavirus the first 2 years of life. But now there are elder children with severe 20, 30 times gastroenteritis. I think this is all of them are COVID. The second comment, you said when you illustrated the symptoms, insomnia. I think no one is taking care of this insomnia. I have few patients, one of my relatives, they didn't sleep for 10 days at all. Yeah, I used to give one of them Camipam to sleep. This is the first time I noticed this as a symptom of COVID.
Yes, some of CNS manifestation not observed well, like مثلا meningism. Can you imagine, Dr. Mona, some patients came with just meningism, just meningeal irritation signs with no other signs. It's very weird illness actually, so we have to be aware of any minor symptoms that can be related.
Have you done virological studies for his CSF or not?
No.
You didn't?
No.
I have a few patients last month, they came with pancreatitis without any symptom of a trauma or pancreatitis, which resolves in 2 to 3 days. But the PCR was negative also. What do you think about this? Have you seen
any history of contact? I have seen cases of DKA and acute abdomen. And some cases during the era of cytokine storm. During the era of cytokine storm, a lot of patients like this were having elevated the pancreatic enzymes.
No, these patients
part of the mucoenteric manifestation
and back pain and lipase and amylase 3000s, 4000s. But we stopped the feeding, oral and fluid by mouth, give them the treatment. They resolved in 48 hours.
Yes. It is written in the literature, and we have seen this.
But I did PCR, they were negative. About 3 patients this era, the last time about 5 patients. What do you think? Have you met something like this?
I met cases with pancreatitis associated with other mucoenteric manifestations a lot, even during wave 1. But negative PCR, I don't think one of them was negative PCR. Maybe this is another strain or something, I don't know.
Okay, thank you so much, Professor Hanan. Our second speaker is Professor Dr. Imam Fouda, Head of Pulmonology Unit. We have a long friendship with each other, me and Dr. Imam Fouda. She is one of my best friends in the Pediatric Department. And هي رجل المهام الصعبة. When I face a difficult case in pulmonology, I said, Iman, help me, الحقيني. And she started reading in it and reaching a very, very rare diagnosis. I used from her to give me the best advice about the very complex pulmonological cases. Dr. Iman is going to answer the most important question asked about COVID. دكتورة إيمان اتفضلي.
بسم الله الرحمن الرحيم. شكر جزيل لزميلتي العزيزة وصديقتي بروفيسور منى الجنزوري، وربنا معاكي في المهمة الصعبة اللي انت بتتحمليها، لكن قدها وقدود. وبشكر زميلتي العزيزة الدكتورة ياسمين جمال. الحقيقة التيم كله متحمل أعباء كبيرة في وقت حرج جدا جدا كلنا بنواجهه. وطبعا يمتد شكري للبروفيسور مصطفى هدهد الرئيس السابق لقسم الاطفال اللي عاصر الويف الاولانيه، وبنشكره على مجهوده الكبير، وبشكر كل ستاف مستشفى الاطفال جامعه عين شمس، مجهود كبير. الحقيقه انا النهارده هحاول اعمل الانسرز لبعض الاسئله. انا عارفه كويس قوي ان انتوا كدكاتره زمايل بتتلقوا اسئله كتيره جدا جدا على الواتس وعلى الماسنجر وايفن في عياداتكم حوالين الكوفيد. الاسئله كتير جدا، فانا حاولت الم مجموعه كبيره من الاسئله ونشوف ازاي نقدر ان احنا نجاوب عليها. الحقيقه احنا اذا كنا في كورونا فيروس بانديميك، فاحنا كمان في ميس انفورميشن بانديميك. واذا الميس انفورميشن بتاع الكورونا فيروس الحقيقه اكثر خطوره من الكورونا فيروس اتسلف، واحنا عارفين كويس قوي ماذا تفعل السوشيال ميديا، مش بس للكير جيفرز، مش بس للبيرنتس، ايفن بالنسبه لنا كدكتور. فاحنا فعلا عندنا ميس انفورميشن بانديميك، ويجب علينا احنا كدكاتره الحقيقه تو اوفركم البيزك اوبستكل في افكتيف كوميونيكيشن مع البيرنتس. دي جزء من مهمنا في المرحله الصعبه اللي احنا بنمر بيها دلوقتي. وناخد بالنا واحنا بنتعامل مع الكير جيفرز او البيرنتس ان احنا اكشولي بنتعامل مع ناس اندر سيفير ستريس، وبالتالي هيبقى عندهم مشكله كبيره في البروسيسنج انفورميشن اللي احنا بنديها لهم، في الهيرنج، في الاندرستاندينج، في الريمبرنج. فخد بالك وانت بتتعامل مع الكير جيفرز. واحنا بنتعامل مع الدكتورز الحقيقه مع زمايلنا وبنتناقش مع بعض في اي كونفرنس، بناخد بالنا ان احنا بنمشي بالترتيب، بناخد الباك جراوند، بناخد السبورتنج ديتيلز عشان نوصل في الاخر للكونكلوجن. دي طريقه تعاملنا مع بعض كدكاتره. لكن واحنا بنتعامل مع البابليك الحقيقه لازم ناخد بالنا ان اللي يهمهم في الاخر هو الكونكلوجن، ويهمهم في الاخر اوصل لهم المعلومه بالشكل المطلوب ريجاردلس اي باك جراوند، وبالتالي ده المطلوب مننا كدكاتره. الميس انفورميشن بانديميك اللي احنا بنتعامل فيه اباوت الكوفيد بانديميك في الدياجنوزس، في التريتمنت، في المستقبل. وهنحاول مع بعض نجاوب هذه الاسئله. اللي احنا متاكدين منه امونج الدايليما دي كلها ان السارس كوفيد 2 فيريولانت فيروس مقارنه بكل الريسبيراتوري فيروس اللي احنا اتعاملنا معاها قبل كده. ممكن ده لانه بيعمل اب ريجوليت لمجموعه كبيره من السيتوكاينز والكيموكاينز، وفي نفس الوقت بيعمل داون ريجوليشن للانترفيرون الفا اللي هو البرايمري انتي فايرال ديفense ميكانيزم. دي حاجه احنا متاكدين منها في التعامل. وات اباوت الكويستشنز اللي ممكن الكير جيفرز يسالوها، لازم نكون جاهزين بالاجوبه. دي المكالمه التليفونيه اللي احنا بنتلقاها يوميا. دكتوره انا طلعت كوفيد بوزيتيف، كويس، وانا حاليا دلوقتي ايزوليتد. واحنا فاهمين يعني ايه ايزوليشن. الهوم ايزوليشن ان احنا نبقي طفل ايزوليتد بهذا الشكل اتس فيري ديفيكولت الحقيقه. واحنا بنجاوب على الاهل لازم ناخد بالنا ان احنا we should limit ال unnecessary prolonged isolation، وفي نفس الوقت we should limit ال unnecessary use of laboratory testing resources. وبالتالي اول سؤال هيتسال لك او الاب هيقوله لك I am COVID-19 positive ومعزول حاليا دلوقتي. For how long my PCR would be positive؟ الإجابة على السؤال ده لازم تكون واضحة منك كطبيب. according للكيرفات المعروفة البي سي ار بوزيتيف هيفضل لمدة أسبوعين بعد ديتكشن للفيروس. عند بدايه ظهور الاعراض البي سي ار بوزيتيف بيبقى بوزيتيف في حوالي 60% من البيشنتس، وهذه البوزيتيفيتي بتزداد لما نوصل لليوم الثامن او العاشر، بيكون حوالي 80% من البيشنت ار بوزيتيف. ده اول سؤال. السؤال الثاني again I am COVID-19 بوزيتيف ومعزول for how long I will be infectious. انا خايف على اولادي وخايف على الناس اللي حواليا. الاجابه again هنرجع للكيرف ونعرف الفيرال ريبليكيشن موجود امتى، ونعرف ان البيشنت اللي عنده اعراض are likely to be infectious خلال narrow window بتبدا من 2 إلى 3 في الانكيوبيشن بيريود او قبل ظهور الاعراض، وتستمر الى من 6 إلى 8 ايام بعد ظهور الاعراض. اجاباتك للبيرنتس لازم تكون واضحه بالايام علشان خاطر المس اوف انفورميشن الموجود عندنا. طيب I am positive وسيمتوماتيك وعندي اعراض كانت موجوده ودلوقتي انا ما عنديش اعراض، هل اقدر اعمل سيرولوجي عشان اتاكد انا بقيت اميون ولا ايه موقفي؟ هنا بنعمل تركيز على ان السيرولوجيكال تيست shouldn't be used to establish the presence or absence of SARS infection او reinfection. احنا بنقول الكلام ده عشان خاطر لا يساء استخدام هذه السيرولوجيكال تيست. طيب another question I was PCR positive for how long I would be isolated. ما اقدرش اتعامل مع اي حد تاني. عشان اعمل discontinuation للايزوليشن for persons of COVID الحقيقه قدامي حاجه من تو استراتيجي، يا اما هعتمد على البي سي ار يا اما هعتمد على السيمتومز. according الحقيقه للسي دي سي just the last week ما قلناش بنعتمد على البي سي ار عشان نقلل او discontinue الهوم ايزوليشن except في كاتيجوري واحده بس من العيانين وهو السيفيرلي اميون كومبرومايز. لكن otherwise مش محتاج اعمل بي سي ار عشان اوقف الايزوليشن، لا انا هعتمد على السيمتومز، والسيمتومز اللي هي اليوم اللي بدات تظهر فيه الاعراض سواء كانت هذه الاعراض ريسبيراتوري او نون ريسبيراتوري. طيب نرجع نجاوب السؤال بناء على هذا الكلام. لو انا بي سي ار بوزيتيف فور هاو لونج اي ويل بي ايزوليتد، اذا انت من الاول ما كانش عندك اعراض it is just PCR positive فانت هتقعد 10 ايام من التايمينج اللي عملت فيه البي سي ار بوزيتيف. تمام؟ طيب انت كان عندك سيمتومز والسيمتومز دي استمرت لفتره، لا انت بتحسب بالظبط فتره الايزوليشن بتاعك 10 ايام افتر سيمتوم اونست او بعد الريزوليوشن اوف فيفر فور اتليست 24 ساعه من غير ما تكون بتستخدم الفيفر ريديوسنج ميديكيشنز. طيب انا كنت سو سيفير كيس لدرجه ان انا دخلت المستشفى او دخلت الاي سي يو، خد بالك انت هتفضل ايزوليتد فتره زمنيه اطول، مش 10 ايام زي اي شخص عادي، لا انت هيبقى عندك 20 يوم بالظبط من اول ظهور الاعراض، لان كشخص سيفير انف انه دخل المستشفى او الاي سي يو بيفضل عنده ريبليكيشن كومبتنت فيروس بياند ال 10 ايام، وبالتالي يور ايزوليشن ويل اكستند 20 يوم. بليز هذه الارقام هي الارقام اللي ابروفد من السي دي سي، فبليز احنا لما نجاوب على الاهل هفضل معزول امتى، هي دي الطريقه اللي احنا هنتعامل بيها مع الاهل. طيب another question، انا كنت بوزيتيف وسيمتوماتيك ودلوقتي انا ما بقاش عندي اي اعراض خالص، لكن عدت البي سي ار ولقيته بوزيتيف. نسمع السؤال ده كتير جدا، هل انا ما زلت انفكشوس؟ الحقيقه ممكن يفضل البي سي ار بتاعك بوزيتيف من الريسبيراتوري تراكت سكريشنز فور ويكس افتر الالنس اونست. وجود البي سي ار بوزيتيف لا يعني بالضروره ان انت انفكشوس، لان زي ما احنا عارفين ممكن جدا جدا ان يبقى موجود بس الريمننت بتاعت الار ان اي فيروس. ما يثبت الكلام ده ان الابحاث اثبتت ان 88 ل 95% من الناس بعد ما بيعدي 10 الى 15 يوم من ظهور السيمتومز بيبقوا ما عندهمش في السبيسمنت بتاعهم ريبليكيشن كومبتنت فيروس. ده الفرق ما بينه وما بين جاست ريمننت اوف ار ان اي فيروس. هذا الكلام ينطبق على الناس الاميون كومبتنت وليس على البيشنت الاميون كومبرومايز بيقعدوا فترات اطول زي ما اتفقنا. طيب بوزيشن تاني ممكن قوي تواجهه ان انا اي واز كوفيد 19 بي سي ار بوزيتيف واتحسنت تماما، وبعدين انا بعد كده اتعرضت واصبحت ان كونتاكت اوف ا كيس واتعاد لي البي سي ار تاني فلقيته اجين بوزيتيف. ده يعني ايه يا دكتور؟ الاجابه بتاعته لو انت عملت الكلام دون خلال 3 شهور من ظهور الاعراض الاولى لمرضك، خلال ال3 شهور دول فعندك احتمال من الاثنين، يا اما انك تكون ري انفكشن يا اما انك تكون ده جاست ريمننت من الفيرست إلنس. التو بوسيبيليتيز موجوده. لكن لو لقيت البوزيتيف تيست بتاعك حصل بعد 3 شهور من اصابتك الاولى بيشور 100% ان انت ري انفكشن. This is the way you are going to answer your patient. another question. I was previously diagnosed as COVID-19 وتحسنت تماما، لكن بعدها بشويه انا بدات اشعر باعراض ثانيه تشبه الكوفيد 19. انا هعمل ايه؟ انا خلاص خفيت من المره الاولانيه. اجين هنمسك الفتره الزمنيه اللي هي 3 شهور. لو انت اوريدي هذا الكلام حصل لك بعد 3 شهور من اصابتك، اعتبر نفسك ري انفكشن اجين، وبالتالي هتعمل فيرال دايجنوستيك تيستنج اجين، وهينطبق عليك قوانين الايزوليشن اجين، وما تقدرش تفك الايزوليشن الا بنفس الكلام اللي اتكلمنا عنه قبل كده. So if you got the infection and was positive وكيورد تماما وبقيت PCR نيجاتيف، هل ده يحميك؟ هل ده يا دكتور خلاص مش هيجيني مره ثانيه؟ Unfortunately الاجابه لا. Reinfection is expected to increase with time نتيجه ان الاميونيتي بتاعه النوع ده من الفيروسات بتقل تدريجي، وطالما بنعيش في زمن الكوفيد 19 بانديميك we expect to see more cases of reinfection. تاني تاني يتعرض لنفس الانفكشن، بس خد بالك ان انت خلال ال 90 يوم الاولى من المرض بتاعك ان انت جالك كوفيد، احتمال انك تصاب مره ثانيه قليل، لكن ما بعد ال 90 يوم انت لايبل ان انت تعاد ان يحصل لك هذه المشكله مره اخرى. السؤال ده الاسئله اللي اتفقنا عليها دي مجموعه بتسالها البيرنتس افري داي في الكلينيك وعلى الواتس وعلى الفيس افري وير. وات اباوت كويستشنز بقى من الدكاتره زمايلنا؟ احنا بنسال بعضينا ليه الفيروس ده بيبقى so severe in some people و left others unaffected. الحقيقه الاقوال المقصوره كتير جدا اللي بتقول ان الغريب في النوع ده من الفيروس ان هو بيصيب ناس كانوا quite young who were very healthy and never had any other illness. وموست اكسبرت الحقيقه ما عندهمش اجابه لهذا السؤال، ليه في ناس اصيبت بهذا القدر من الشده وناس ثانيه جات لها المساله بشكل خفيف. يمكن الاجابه على السؤال دون ترجع الى الانوكيولم سايز، الفيرال لود، الجينيتيك هيتيروجينيستي، الميوتيشن، البوليمورفيزم، البايوتايبس، البلاد تايب، الايفكت اوف 6، الايفكت اوف ايج، البادي ماس اندكس والاوبستي، الاميونولوجيكال والنيوتريشنال ستاتس اوف ذا بيشنت. كل دي ثيوريز، بس الاهم ان وجود الكوموربيدجي واحده من الحاجات اللي بتخلي الالنس يجيلك فيري سيفير. الفينوتايب بتاعك ات بريزنتيشن لما بتتعرض لهذا الفيروس هو اللي بيحدد البروجنوزس بتاعك وبيحدد الريسبونس بتاعك للتريتمنت. الحقيقه في حاجه اسمها اتش فينوتايب للكوفيد 19، دول مجموعه من البيشنت ما بيقدرش يتوقف عندهم السيتوكاين ستورم تماما، وده بيبقى تميزه ان هم بسرعه جدا مع هذا الفيروس بيخشوا في بور بالمونري كومبلاينس، بيخشوا في سيفير اوكسجينيشن فيلير. ودول الحقيقه لما اتعمل لهم هيستولوجيكال اكزامينيشن لقينا ان بيحصل لهم في اللنج وات از كولد از اكيوت فيبرنس اورجانيزنج نيمونيا. بناء على هذا الاساس بيبقى عندهم بالمونري فايبروزس برولونجد فنتليتور ديبندنسي وتنتهي بباد بروجنوزس. وات اباوت بلاد جروب؟ هل البلاد جروب بتاعي ممكن يحميني بشكل ما من الاشكال؟ يس. الحقيقه الناس اللي عندها بلاد جروب او عندها احتمال اقل للاصابه من بقيه البلاد جروبس، دي اوبزرفيشنال ستاديز، لكن لما تصاب نفس احتمالات الهوسبيتاليزيشن ونفس احتمالات الباد بروجنوزس قائمه. الكلام دون اتحطت له مجموعه كبيره من النظريات. يمكن قالوا ان الانتي انتي بودي الموجود في بلاد جروب
اللي هم بلاد جروب او
انفكشن
ريتس
اي بلوك حقيقي الانتي بودي الحقيقه بتبلوك اللينك ما بين الفيروس والانجيوتنسين كونفرتنج انزيم. نظريه ثانيه كمان حديثه بتقول ان اللي عندهم بلاد جروب او بيبقى عندهم ديكريزد ليفل لفاكتور 8 وانفولفري براند فاكتور، وكون ان هم قليلين عندهم بيخلوهم اقل عرضه للفاسكولار complications للبلمونري سيستم نتيجه الكوفيد. They are all these theories ليه ناس اصيبت بشده وليه ناس اصيبت اقل. وبناء على هذا الكلام الماجيك بوليت للبريفنشن والتريتمنت اوف كوفيد؟ unfortunately no magic bullet. احنا ما عندناش سنجل دراج يبقى افكتيف في علاج الكوفيد. الحقيقه احنا عندنا مالتيبل دراجز بتشتغل بديفرنت ميكانيزم في ديفرنت فيزز اوف ذا ديزيز. البيست تايم ايه؟ لازم نبقى عارفين توقيتات الفيرال ريبليكيشن، وجود الفتره اللي فيها اميون ديسريجوليشن. يعني الانتي فايرال نقدر نستخدمها في الاول 2 ويكس لان دي الفيرال ريبليكيشن، بينما الانتي انفلاماتوري ملهاش دور في المرحله الاولى لكن ليها دور في الايرلي بالمونري والليت بالمونري فيز. يبقى انا لازم ابقى عارفه كل دراج هستخدمه ايه المرحله بتاعته. احنا في الايرا بتاعت استخدام الايفرمكتين بديفرنت بروتوكولز، زي ما قالت زميلتي العزيزه الدكتوره ميرفت احنا فين من الايفرمكتين؟ الحقيقه كل تجارب الايفرمكتين كلها ان فيترو ستاديز اللي قالت ان احنا لما جبنا خلايا انفكتد بالفيروس وعرضناها للايفرمكتين، الفيرال ار ان اي ليفل والسيل اسوشيتد فيرال ار ان اي نزلت جدا بعد 24 ل 48 ساعه. This is all in vitro studies. وقالوا ان السبب بيرجع الى نوع معين من البروتين بيتعامل مع الايفرمكتين اللي هو اسمه امبورتين، بيبقى مسؤول عن دخول الفيروس داخل النيوكليس عشان يبدا يحصل فيرال ريبليكيشن. حقيقه ليه الايفرمكتين بالذات بداوا يشتغلوا عليه؟ لتجاربنا السابقه معاه في ديفرنت فيرال انفكشن. وبناء على هذا الكلام بعض الجايد لاينز زي الفرونت لاين كوفيد كريتيكال كير الاينس قالت ان احنا نقدر نستخدمه في البروفيلاكسيس والتريتمنت، وحطيت له دوزز 0.2 مللي جرام بير كيلو جرام بير دوز. بس عايزه اقول لكم ان جميع البروتوكولات ما بتشبهش بعضيها في عدد الايام اللي بياخدها العيان. لكن لو رجعنا للمصداقيه بتاعتنا which is the CDC لما اتسالت السؤال ده just 2 days ago استخدم الايفرمكتين to prevent or treat COVID، الاجابه كانت نو. وقالوا ان احنا ما زلنا محتاجين مور ستاديز عشان خاطر نتاكد اذا كان نقدر نستخدمه او لا. بس امبارح يوم جانيوري 7 ميدسكيب جاوبت على نفس السؤال اذا كنا نقدر نستخدم الايفرمكتين، واجين قالوا ان الدوزز اللي استخدموها ان فيترو كانت دوزز عاليه جدا قد لا نستطيع ان احنا ناخدها كاورال. فستيل الايفرمكتين الحقيقه عليه ديبيت كبير. الكوفيد مش بس هيعمل لنا مشاكل وهو موجود، ده هيعمل لنا مشاكل بعد ما يخلص. وات از كولد از بوست كوفيد سيندروم. الناس بتسالنا هيحصل لنا ايه بعد كده يا دكاتره؟ حاجه هتحصل اسمها لونج هاول سيندروم، بتحصل الحقيقه للكبار والصغيرين، للي عنده كوموربيد كونديشن واللي ما عندوش، للي اتحجز في مستشفى واللي جات له مايل سيمتومز واتعالج في البيت. بيحصل في 10% من الناس اللي حصل لها كوفيد ان يحصل لها بعد كده كوجنيتيف بروبلمز، فاتيج، انتولرنس تو فيزيكال اند منتال اكتيفيتي، ديليريوم، هالوسينيشن، شورتنس اوف بريث، مجموعه من السيمتومز تنطبق عليها كلمه برين فوجز. يعني الناس دي بيحصل لها some form of being confused or unable to concentrate. الكلام ده راجع لايه الحقيقه؟ ملوش ثيوري محدده. ناس قالت بريزيستنت هايبر انفلاماتوري ستيت، ناس قالت لا ده الفيروس ما زال موجود في ريزرفوار انسايد ذا هوست، ناس قالت لا ده نتيجه كوموربيد كونديشن، ناس قالت لا ده نتيجه الديفيكالت سيتويشن اللي مر بيها المريض. على جميع الاوضاع الثيوري مش معروفه نهائيا، لكن لما اتعمل MRI للبيشنتس دول الحقيقه لقينا ان 55% منهم عندهم مايكرو ستراكشر تشينجز سبيشالي في الفرونتال لوب. هلفت نظركم ان ده بيبقى اكتر من الناس اللي عندها CRP عالي قوي ات برزنتيشن، دول بيبقوا لايبل للبوست كوفيد، وبالتالي العيانين دول بننصح انهم ياخدوا ستيرويدز لفترات طويله ويتعمل لهم فيري سلو تيبرنج. هو ده بيحصل في الاطفال؟ يؤسفني اقول لكم ايوه بيحصل في الاطفال، وبدات الكيس ريبورت تقول على اطفال عمرها 12 concentration, so it can happen for everyone. more pressure مع appearance of new strain من الكوفيد 19 الحقيقه، والنيو سترين ده ضغط علينا ضغط شديد جدا. هو ايه؟ هو اعلن عنه في ديسمبر 19 في يونايتد كينجدوم وتسمى سارس كوفيد VUI، او قريتوا الترم ده اسمه فاريانت اندر انفستيجيشن في 2020 شهر 12. الفيروس ده الترانسميسابيلتي بتاعته عاليه جدا، اكتر من 70% من الفيروس الاولاني، واعتقد ان احنا كلنا لاحظنا كده ان الفيروس اليومين دول بياخد الفاميليز كلها، قدرته على الترانسميشن عاليه جدا، عنده مالتيبل سبايك بروتينز بتعمل بيتر بنتريشن للنيزل ميكوزا. لكن الخبر الكويس الحقيقه ان هذا الفيروس does not increase the risk of this، وانه اتفصل في بعض الناس اللي هي كانت even asymptomatic and self isolation، لكن هي مشكلته انه بينقل العدوى لعدد اكبر من الناس، لان الريبرودكتيف ريت بتاعه اعلى من الفيروس الاصلي، كان الاولاني 1.1 دلوقتي 1.5. ده حصل منين؟ من الفاكسينز. الحقيقه ما نقدرش نظلم الفاكسين اطلاقا، لان ظهور النيو سترين لسه ما كانش الفيروس بدا يشتغل او يعمل اي مشكله. ناس قالت ان ممكن يكون نتيجه ان ده في سنجل، ان حدوث prolonged انفكشن في سنجل بيشنت بيخلي اكيوميليشن لحاجه بنسميها اميون اسكيب ميوتيشن. وناس ثانيه قالت ان دي نوع من الادابتيشن بروسيس ان ا فيروس ذات اوكير ان ديفرنت سسبتبل انيمال سبيشيز. عشان كده اتفصل في الدنمارك لما الفيروس انتقل ما بين الانيمالز المينك وما بين الهيومن بينج. All these are theories about this virus. السؤال الرئيسي بقى اللي احنا بنسال نفسنا فيه بيننا وبين بعض كدكاتره وبيننا وقدام الاهل، ولازم نجاوبهم بابتسامه زي ما انتم شايفين، احنا الفيوتشر بتاعنا اخباره ايه؟ هو الفيوتشر بتاعنا كده مظلم؟ لا، الحقيقه هنسال نفسنا سؤالين. How long will concern about COVID will last؟ الحقيقه هيفضل الكونسيرن ده موجود طالما الفيروس موجود، وطالما الفيروس بيسيركيوليت اند سبريد، وطالما بيأثر على الايكونومي والهيلث والافري لايف. حياتنا هترجع لوضعها الطبيعي بالاكتيفيتيز، الحقيقه مش هيحصل الكلام ده بسهوله طالما الفيروس موجود، وهنلاقي نفسنا بنتعامل مع الاشكال دي من التعليم، لان احنا الفيروس ما زال قائم معانا. نقدر نعمل هذا الكلام، نقدر نقول السنه دي هيبقى وضعنا ايه؟ هتفضل WHO معلنه ان كوفيد 19 بانديميك until no longer large outbreaks of new cases or deaths in many countries for a specific time period. وبالتالي توقع ان هذا الفيروس عايش معانا كبانديميك for the coming many months. نقدر نعمل ايه عشان تموديفاي الكلام ده؟ wide spread testing, preventive medicine, contact tracing, treatment, vaccines. وفيري سون ان شاء الله هيصبح هذا الفيروس باست، هيصبح انديميك زيه زي اي فيروس زي السيزونال فلو والكول، بس الكلام ده هيحصل امتى احنا مش عارفين. نقدر نعدل حاجه في حياتنا، الحقيقه كل الاكسبرت بيقولوا المفتاح الموضوع هو البابليك، الناس العامه لازم عندها في سنس اوف بيرسونال ريسبونسبيلتي، ده مهم جدا عشان نقدر نظبط الموضوع. واز لونج ان ده السنس اوف ريسبونسبيلتي في البابليك عندنا حتى الان، واز لونج ان احنا مش قادرين نستخدم الماسكات بالقوه دي، فاحنا هنعول على الفاكسين اللي هتكلمنا عليه استاذتنا القديره الاستاذه الدكتوره سناء. قبل ما اقفل عايزه بليز stay safe, stay stronger, do your part by staying apart. انا عايزه اشكر جدا مستشفى الاطفال جامعه عين شمس، شايله عبء كبير جدا في التعامل مع الكوفيد كيسز. عايزه اشكر الفرونت لاينرز الريزيدنت اللي مواجهين كل لحظه مشكله. عايزه اشكر التيم بتاع الاي سي يو اللي بيتعامل مع الحالات بسرعه شديده جدا جدا وبقدره وتمكن. عايزه اشكر تيم الشيست كله انكلودنج الصغيرين اللي هم موجودين في الجنرال وبيواجهوا هذه الحالات. عايزه اشكركم جميعا على وجودكم معايا النهارده، واي هوب ان اللقاء القادم يكون فيس تو فيس. شكرا جزيلا. ثانك يو. دكتوره منى افتحي الميوت، افتحي الميوت يا دكتوره منى.
Thank you so much دكتورة إيمان فودة. It was a very very nice lecture. أحلى حاجة فيها إن هي practical and it answers the most important questions اللي طول النهار دايرة in our mind and in the family minds. Thank you so much. و last but not least عندنا professor eminent professor دكتورة سناء. أنا شرف لي إن أقدمك يا دكتورة سناء محمود والله Professor of Pediatric Allergy and Immunology in USA. She's going to give us updates in vaccination. دكتورة سناء will start. دكتورة سناء.
Just a second. Yes, please. I'm sharing the screen. Just a second. I'm sharing.
دكتورة سناء السكرين شيرد بس عاوزة تبقى تاخد كل
I
نطبق.
wanted the top. Okay, hold just a second. Bismillah ar-Rahman ar-Rahim. Good afternoon or good evening, everybody, and thank you really very much for always having me with you. And it's my honor and pleasure to present a little after all those eminent speakers. And I hope you're still awake so they can watch what I'm going to present to you. All right. Let me tell you this. With this, like, is it still there? With that fast-moving pandemic, it's expected that no one will be safe unless all of us will be safe, as you've seen just from the presentation of Dr. Iman and everybody. And this is not me, this is the WHO. All right, here we go. I don't know what happened. All right. The world will not return to its pre-pandemic until safe and effective vaccines, will be available, as well as global vaccination is implemented. What is herd immunity as per the WHO? The herd immunity is supposed to be achieved by vaccination, not by waiting till everybody is infected. What we know, the measles herd immunity is about 95%. What about polio immunity? It's about 80%. Vaccination to COVID, will it yield the same number? Unfortunately, I cannot say that. I cannot promise you that because it's not yet known. What is usually said is between 50 to 80%. Epidemiologists will say that. It means that for us here, from 300 million 25, 200 million should be vaccinated. And from the whole world population, 7 billion, you need 5.6 billion people to be vaccinated. Let me review a little bit of the steps so that you will understand what's going on. This is, and don't say that this vaccine had been rushed or this vaccine is not good or whatever type of vaccine is not good, and why, since the process is that lengthy, what happened? We know that what we call the exploratory phase or the preclinical phase that takes time and usually takes between 2 to 5 years. And this is the lab or the animal studies. Of course, it takes a lot of money. This is followed actually by phase 1 and phase 2. Phase 1 is carried on hundreds of patients, like less than 100 of patients, and phase 2, few hundreds. And all the studies that are published for now are phase 1 and phase 2. A few reports from phase 3, no real published data in scientific journals from phase 3. Phase 2 also takes around few months and less than a year, and it takes millions. What about phase 3? Phase 2 is the same again. It takes around 2 years. What is the difference between phase 1 and phase 2? They check the immunity in animal and the human beings, of course, before this in human beings, as well as making sure that this dose is safe. And that's why when I'm going to present some of the slides, you will see the differences in the doses. Then the phase 3 were the efficacy trial, and this is the one that is carried on thousands of volunteers that we owe them all the credit, because those guys that either they were in the placebo and only one in the placebo person had died from COVID, so they exposed themselves to feeling that they are having sense of security, and they are not actually. Till after that, the post-marketing. So having said that, varicella was, it took around 25 years to develop when it was first discovered in the 70s, and the first varicella vaccine approved in 1995. The fastest ever vaccine was the mumps that took around 4 years. Timeline for the corona vaccine was set as 1 to 2 years. Why? Actually, the Science magazine and then the other over the world, the research and development made sure that there is industry involved, government is involved, and academic institutions are involved. It's not a one-man job. For the states, it's the OWS, it's what we call the Operation Warp Speed, plus the active intervention, plus the COVID network. And those are responsible, the first one for the strategic approach and coordination, and then how to involve the public-private sector, and then the NIH funded the studies. And those $10 billion were allocated to be spent on the vaccine development. And that's the reason why the vaccine was in the market even before a year. It's not because drug companies want to make money. We cannot survive without pharmaceuticals. The research that they are doing is a mutual benefit. We physicians, we cannot say that everybody wants a share in the pie. We are all in the same situation, as you all have noticed. The health department, the research, as well as the Ministry of Defense, which here, actually, they recruited a lot of, and we owe them the credit for people to be there. The Operation Warp Speed actually standardized this all over the world. It has to be randomized, placebo controlled. You cannot tell me studies with just few patients without randomization. Count has to be in thousands. Age was first above 18. The endpoint efficacy was set to be 60%. So if I tell you, for example, the Chinese vaccine is 79% effective versus the messenger RNA, which is 95%. Are you doubted? No, it is the set point. You're not expecting everybody to be having good response. And then the immunogenicity analysis is based on one and the same. Those are the trials all over the states, from the states to South America and then South Africa. Egypt is involved in 2 of the trials. So what about the World Health Organization? Is it sharing with the same thing? Yes, they said actually three names that you should know. COVAX, and this COVAX is responsible for providing at least 20% of the country's population to receive different forms of vaccines, not one vaccine. You might receive a vaccine and your neighbor will receive another vaccine. And then the preparedness, and you will see this abbreviation again from the unit, another one. And then the third one is the Gavi. When you see the Gavi, which is the public-private global partnership, Bill and Melinda Gates, they just part of it. But the Serum Institute of India is part of it. The World Bank is part of it. The UNICEF is part of it. So everybody's sharing. It's a matter of how to get the money. The UNICEF, then the World Health, WHO allocated $2 billion. So you have there, those are responsible for the spread of all vaccines, that every country will have a different share of the vaccines, whether through purchasing, whether through provided WHO, whether through the company. For example, the COVAX said the deals that those are big numbers. I'm not going to bother you with that, but you are going to see the AstraZeneca, Oxford, you're going to see the Novavax, you're going to see the Johnson & Johnson, Janssen Pharmaceutical, you're going to see the Sanofi, Aventis, GSK, the same thing for us here, maybe a little different. Two websites that I want you please to remember, and this actually I have my email. If you want this presentation or part of it, you can email me. This what we count for is the infectious disease website. Very reputable one, and the best one that you can follow and track the vaccine development, the London School of Hygiene and Tropical Medicine. And they actually update themselves every week. And as of yesterday, I was looking every day, we have 291 vaccine candidates and 68 in clinical trials. Imagine how many vaccines are going on. We have only, and then different, of course, you will see the different numbers, different phases, how many approved, how many licensed, the RNA vaccines, the non-replicating vector, what we call recombinant or viral vector vaccine, and the inactivated vaccines. Are they approved by the FDA or approved by WHO or approved in China? I will let you know in a second. How many in each phase? You can find this at your own pace. Is Egypt taking part of it? Yes, they are taking part of the tour, and there are the name of the trials of Wuhan Institute of Biological Products, as well as Sinopharm, Sinovac and Sinopharm, and CanSino, which is the adenovirus. So coronavirus, is it a science or a conspiracy? It's not a conspiracy. Definitely, what I'm going to show you, nobody's going to put a chip in the brain of somebody to trace it. Nobody cares about it. We need to care about ending this pandemic. And it's not actually the WHO and the fundraisers will give the vaccine for free. It's not a matter of making money. I'm going to go to this friend that we, unfortunately, we have his friendship for a year now. This is the coronavirus and the cryo-electron microscopic picture. And those are the different antigens. And this is the antigen that is the presenting part that we know, that the S antigen and the RBD part of it. Most of the vaccines, or some of them, will be directed against this S antigen, and the rest of the vaccines will be dealing with something else. So the vaccine subtypes will be someone dealing with the specifically to the presenting part, to the RBD, and some of them will have the S1 of the S antigen or S2, or some of them will have two of these, or some of them will have the whole virus or part of the virus, different forms, that what we call different platforms. You will be asking, as what just Dr. Fuda just mentioned, the new variants. And when it was published early December that the UK variant that they would discover that is called the lineage B117, and then followed by the South African lineage, which is 501Y, those are 9 amino acids changes out of 1,270 spike proteins encoded by the messenger RNA for the S protein. Is it expected that the vaccine will be effective? According to the Infectious Disease Society of America, the vaccine will be still probably effective for more than 2 to 3 years. And as of today, Science Journal just published the persistence of the cellular immunity for the MERS vaccines or like the trials or some other vaccines for 17 years. Is it probable that you're going to have mutations? They said that in order to change it genetically, it takes a lot of cycles. That's why when you reinforce it, the social distancing, the mask, decrease the transmission, try to keep yourself healthy, to make sure that this virus is not going to be all around us for a long time. But at least the vaccine will be there for some time. The good question is that just for the just mentioned, this vaccine, the FDA actually, the CDC and the FDA had both said the 90 days. The current evidence is that reinfection is uncommon. So what exactly said, they left it for you. Individuals with documented acute infection in the preceding 90 days may delay the vaccination until the end of this period if desired. Do you see the difference? Do you give or not to give? Actually, it's really kind of confusing, and it's left to the decision of the treating physician. In a simple way, in order to make vaccines, I will give you the whole idea. You either use the whole pathogen, or you use part of the pathogen, or you use the genetic material of the pathogen. Meaning, you're going to use this and you inject it. Is this the way that we are expecting? Yes, we are now having the injectable ones. Are there going to be intradermal ones? Yes, still not actually out of the 4. But do you think that nobody wants to be injected and they say that everything stays in the cell? Are you going to trust the respiratory mucosal one? One is coming soon with adenovirus. Is it enough? No, hang in there. There will be an oral one that is nicely, they are using DNA vaccine. It's a DNA vaccine using bifidobacterium, and it's a 1 dose using 1 million, and it will be absorbed through mucosa presented to your immune system. Will there be a cutaneous one? There will be a microneedle, and it's Pittsburgh scientists are working on the cutaneous patch. So definitely no single vaccine will be available for everybody. No single vaccine will cover everybody. No single vaccine, as I said. So different platforms, everybody will have whatever side effects and reactogenicity, but are there going to be enough people to trust the efficacy of the vaccine? Are you going to take it? That's the whole question. Everybody, I'll tell you myself, I took my vaccine. Am I consider myself a guinea pig? I don't think so. The second question is, when you ask, I took the vaccine, but are you gonna, am I gonna stay only for 3 months having the protection? Am I gonna have a false sense of security that this vaccine is working? This study was just published, as you can see, yesterday. From the New England Journal of Medicine, from the first few people that they took the trial 1 and trial 2 with the messenger RNA, only 34 individuals. They looked at the neutralizing antibodies and look at how many days followed up, 119 days, 3 months, and you can see how beautiful the level of the immunoglobulins. Yes, in the like some groups, especially as we grow older, we know that the immunity decreases. They are still, Th1 is detected after 45 days, and still they are working on the memory cell. They are still working on the cellular. So preliminary data are showing that the vaccine is working. Don't know why it's stuck. Those are the 5 platforms that I told you about. Platform, the different types, either the inactivated and the one that you're going to have in Egypt, the Sinovac and Sinopharm, or a live attenuated, I'm not going to bother you with, it's not there yet, or a subunit from the virus that I just told you. This is the Novavax, GSK, known names in vaccine formation, Sanofi Aventis, viral vector, the Oxford vaccine that has been approved in England and will be distributed soon, Johnson & Johnson, as well as the Chinese one, the CanSino. DNA, the Inovio that they're working now, phase 1, and the released ones, the Moderna and BioNTech. So what has been approved is the messenger RNA, the inactivated vaccine, as well as the viral vector vaccine. And probably you're going to take one and your neighbor will take another one. In short, a little bit of immunology in that. How do vaccines work? We know that the virus first will go inside and the virus will release the messenger RNA. So the genius, the next, what we call it next generation vaccines, they thought that we don't want the virus, we can use this messenger RNA. That has nothing to do whatsoever with the nucleus. It is in the cytoplasm. It will go simply to the ribosome machinery to translate it into amino acids to be taken care of in the proteasome, to be packed in the endoplasmic reticulum, to add the plate, which is the MHC1, to be presented to your T cell, the master cell of the immune system. Very simple. So they said, okay, so what happened with the viruses? Those are the cells that I need you to know, because when you read a study or any research, you're going to see cellular and they standardize that, cellular and antibodies. The T cell, the B cell, the antigen presenting cell, and the CD4 cell. The antigen presenting cell actually present to two types of cells. So it presented the antigen after being digested through the MHC class 1 or MHC class 2. MHC class 1, you know, all viral infected cells use MHC1 to present it to the CD8 cell. And then the MHC2 presented to the CD4 cell. This is basic immunology. CD8 is the killer cell. It uses perforins, granzymes, ligands. It will kill. But will it remember? You might clear the virus with this, and you might not have memory. And you will say, what happened to me? I don't have anything. Because the most important thing in the infection or in the vaccine is to develop memory cells, so that even if the levels of every cytokine, everything goes down, still the memory cell is good. I'll walk you through the steps. If you go through like real infection, coronavirus will go into the cell, will release his friends, coronaviruses, and will be ingested by the antigen presenting cell. Why? Because your immune system is very, this is the adaptive, by the way. It can be taken care of by the innate. I'm not going to talk about it, and that's the problem. Sometimes the innate will get rid of it before anything else. So the virus infected cell, the CD8 will need the tiny amount of the virus. If the antigen presented to Th1 will be going to the CD8, and I told you this is the killer cell, but it can be presented through MHC class 2. Then it will go to Th4. This is a good mastermind of the immune system. This will tell Th1 to help the CD8, and it will help the B cell. The B cell is the one that will produce the antibodies that you wanted and will produce the memory cell. All the vaccine idea count on that. Living attenuated or inactivated will do the same thing in a weakened form, in a non-pathogenic, but the whole virus will be taken. Simple, old idea. The messenger ones, when they use your cell, yes, they use your cell, but they use your cell not to produce a virus, not to go back, retrograde to the nucleus, but to produce this tiny part, to get the digested form of the stuff, to make the cell produce this one. Your cell will work, make this protein. It's not going to affect you. It will make this. Why? Because it actually degrades itself in no time. In few weeks maximum, you're not going to see this antigen. But the few weeks are enough to go through the stimulation. If you give it through the Oxford vaccine, you put it in a virus, and the cell will do as if it's a virus infected cell, not by the corona, but the inactivated adenovirus. Or the one that simply said, okay, forget about the whole cell. Let's give a little bit of proteins, a virus-like particle or a subunit. It will go immediately again to this star cell to be presented to the same way. So those are the mechanisms. Effective vaccines should then be neutralizing antibodies from the B cell and Th1. Why Th1? Because this Th1 has the interferon that there are some medications, TNF-alpha, IL-2, those are the needed ones. every vaccinologist is afraid, and we are afraid from the increased virus replication when you give a vaccine. How many of you had the flu vaccine and got a flu? You tell me, I take the vaccine and I get an infection. Fortunately, it's the good luck of the virus. When the virus find non-neutralizing binding alone, they are wicked. They use it to enter the cell through the FC port. And then once the virus inside, here the wicked face will appear. They will suppress the Th1 that will produces the interferon and the TNF, and will suppress the antiviral responses, and he will be happy giving virus replication to himself. Will it happen with the vaccine? There's sometimes cytopathic effect. And that's why when you say, when you have the vaccine, you get the disease. This is the part of it, what we call the ADE, that is supposed to be avoided by all vaccines. Let's see the live virus and the inactivated. The live virus vaccines, do we take them? Yes, we take measles and we take mumps. There are some in the preclinical trials. I'm not going to talk about it because it's not there yet. Of course, they are not given to immune deficient, and you know that. Let's go to the second type of the vaccines, the DNA and the RNA vaccines. First, I'm sorry, before that, we're going to go to the inactivated. We haven't done this. I apologize. The inactivated vaccine, the hepatitis A that you started giving to the kids, is an inactivated vaccine. The polio vaccine that we switched from the salt from the sebum to the salt is an inactivated vaccine. We say that the immunity lasts for years in that. Is the immunity from the vaccine that inactivated will last for years? I cannot tell you, I cannot promise you. They are still working on that, but we hope that they are stable as compared to the live. And they use definitely, because you weaken it, you need to add some adjuvants. And people were afraid from the thimerosal and autism and stuff like that. They said, forget it. They use alum and CpG molecules that are relatively, I cannot say 100% safe, because for you to cross the street, it's not safe. For you to make salad and use the knife and cut the salad, nothing is absolute. There are like white and black and gray zones, and any surgery, there is nothing absolute 100%. Any vaccine, nothing absolute 100%. But we as physicians, we understand, and you preach people and you advise them, and they make the choice. They are poor inducers of the CD8, the killer cell. They need boosters. Of course, people preparing them, they need large amounts. They have, of course, to cultivate the virus in an animal and get it, multiply the virus. And as I said, they use the adjuvants. The Sinovac company, Chinese company, do they take the like if you ask, CDC is not related to the China in this way. WHO, they have their own regulatory stuff. I tried to find how they approve it. Of course, it's not easy to get published clear data. They publish, but you don't know the steps. Like I can trust the data that I'm presenting from the New England Journal of Medicine or anywhere else. The inactivated, like also the influenza, the Hep A, and the polio. And this one, they said the early results said that efficacy 91%. Phase 3 were done in China, Brazil, Indonesia, and Turkey. Brazil gave us very conflicting data, between 50 to 90%, but they have not released the final data yet. Turkey, just on December 25th, they released efficacy of 91%, but they tried it on 1,322, not on tens of thousands, the vaccine group equal amounts, and they said the COVID vaccine was detected in 26 placebos and 3 in the vaccine group. Do you trust it? I trust it. What is the early studies that were done and published in the Lancet? Phase 1 and phase 2, as I told you, early ones on hundreds or less than 100. On 144, 2 doses, day 1 and day 28, the outcome was seroconversion to good neutralizing antibodies. They did not find, as I told you, CD8 and mild side effects. They did not report the side effects. And this is, you can see here, they try, as I told you, in the first and the second trial, they use different dosage, and that's why you can see different ones. And they studied the antibodies, as you can see, spaced between day 1 and 14 post vaccination first dose, and the second dose day 1 and day 14 days and the 28 days. And you can see, I want to show you the trend, not the details of the antibodies. to the receptor binding domain of the IgG receptor or the whole neutralizing antibodies. And it's a really good result if you say, if you find it this way. What about the second Chinese vaccine, the Beijing Institute of Biological Products, the Sinopharm? It's an inactivated. They use beta propionolactone. You're gonna tell me this is carcinogen. No, it's not. It's carcinogen if you use it or inhale it. But they use formalin actually for the polio. Are you gonna tell me that formalin is toxic? Those are used definitely with a lot of safety margin. I'm not in the place to judge a vaccine to that extent. We have committees that judges that. They use alum as an adjuvant. It has been used in Egypt, Bahrain, Morocco, Pakistan, and United Arab Emirates and Peru. On how many? 60,000. No published data yet. What is the efficacy? 79.34%. United Arab Emirates said that their phase 3 trials with no detailed data was 86%. They reported side effects in 73 volunteers, high blood pressure, loss of taste, but the published data is not there yet. As of January 3rd, Egypt approved the Sinopharm. This study for that vaccine, the safety and immunogenicity was done on 1,192 in 2 doses. They used the different, as I told you, dosage group and the 2 groups, individuals, the young and the elderly, with aiming at the same neutralizing antibodies. And you can see how shooting the neutralizing antibodies based on post-inoculation with the different dosage, and based on that, they choose the appropriate dose. This is the plant in China, the Sinopharm, that claimed that efficacy. What about the viral vector vaccines, the recombinant vaccine that you're going to soon have it? What happens is that, as I told you, all those vaccines were tried before, like for HIV, for Ebola, for the Zika, for the other vaccines. They use adenovirus, they can use chimpanzees virus, they can use animal viruses, it's called the VSV, different pox viruses. The whole idea is that they weaken the virus and they put the genetic material from this coronavirus inside this weak virus. So this virus will make the S antigen, and here, this is the one that is injected in the human beings, and then you produce the antibodies. That's what we call viral vector vaccines. They are high specific gene delivery, they are non-replicating, and they produce, it's a cellular one. It reduces a cellular and good immunity, but there might be some reduced efficacy. If I tell you that, will be afraid? No, I will show you the studies. Actually, the studies with 2 different levels of neutralizing antibodies to adenovirus, that we all had the adenovirus, and they had no problem. Actually, did not affect the virus. How about the integration of the viral genome or risk of reversion? This is, again, a risk. I'm saying a risk. Documented, I don't know. What are the groups of the adenovirus? Oxford AstraZeneca is an adenovirus based, Johnson & Johnson, CanSino Biologics, as well as the Russian. Russia had not revealed also a lot of studies, and I don't know whether it's going to distribute to the whole world or not. But the Oxford vaccine was given in 2 doses between 4 to 12 weeks apart after 3 months. And the distribution is 2 to 8 degrees centigrade, which is very good. And they published the results on the first 1,000 individuals. And you can see they used, you can see here the convalescent, and you can see the different levels of the neutralizing antibodies. In the pooled analysis data of the 3 trials on 11,000, they found 131 COVID cases, 30 in the vaccine versus 101 in the control group. And that's how they came up with the efficacy trials. They used the 2 doses, and to tell you the truth, they said the first half and full dose was a lab mistake. They used less and then full dose, and then after that they used full doses. And look at that, the immune system, when triggered by less and more, give you a very good response. When they had the 2 high doses, have you suppressed the immune system? What happened? I don't know, but that's why you have an efficacy of 70%. No severe corona cases in the vaccinated group, and as I told you, the storage is very good. Oxford safety data, they had now the higher group, stage 3. following and followed up after 3 months from the first dose and 2 months from the second dose, they found 168 serious adverse events, 79 in the vaccinated and the rest in the placebo. One possibly related to the vaccine, transverse myelitis, 14 days after the second vaccine. Is this gonna make you not take the vaccine? Guillain-Barré happened after flu. We all take flu. As I said, I have one patient, I gave him the flu like 2 years ago, and he had Guillain-Barré, and unfortunately enough, he keeps coming to me. I don't know why. I wouldn't have done that. In one control group, there was a hemolytic anemia, and the limitation, they used first a small age group. Johnson & Johnson, I'm not going to talk about it. They used the 2 different types, and still the trial's not there yet. CanSino, I don't know how fast China will release this. They did non-randomized stage 1 first, 108 individuals, and they checked the binding antibodies, T-cell responses, and you can see here day 0, day 14, day 28, day 0, day 14, and they checked the pre-existing antibodies, and they checked the pre-existing at 2 different levels, and they lump summed everything. Even with the pre-existing antibodies to the adenovirus, the vaccinated people mounted a very good response, as you can see here, and they checked also CD4 and CD8, and you can see a robust immune response, the effect of the adenovirus titers, and you can see that. How about the DNA and RNA vaccines? DNA vaccine, if I tell you DNA, it's a vaccine technology. It's not our DNA. They use naturally occurring DNA plasmids. They are temperature and cold stable, fast production, robust immune response. Whenever you go down, of course, inside the nucleus and the genetic material, you get a robust immune response. Safe, no handling of infectious material, but the fear was abnormalities in the cells or production of self-antibodies or the immunogenicity or the multiple dosage, because they implemented inside your DNA at this point. But here, still phase 2 and phase 3 with those studies, I'm not going to talk about it now. The RNA vaccines that I already taken mine a couple of weeks ago. RNA is very fragile. It's non-infectious. It codes for the S protein and lasts for weeks only. This S protein is degraded because our bodies are capable of doing that. No risk of integration in the host genome, no insertional mutagenesis, because there is no integrase enzyme and no reverse transcriptase. And even, I'll tell you, some of the trials were done on stable HIV individuals, but the results are not there yet. It's minimally immunogenic, allowing repeated administration. We don't know whether it's going to come. Still, I cannot swear what will happen. It's transiently expressed, metabolized, so it's safe, and no effect on the PCR testing. Excuse me. But the limitation is the safety with the reactogenicity. Reactogenicity means reaction to the vaccine components or items, and instability. The mechanism, as I told you, uses the RNA, so your own cell will produce the S antigen that will be produced there. Definitely you're going to get some of the Pfizer, because Pfizer had promised to produce 1.5 billion doses in 2021. Moderna had promised 1 billion doses, and they already had millions of doses distributed. So I think they will increase the production. The phase 1, phase 2, as you can see, I'm not going to go into the details again. You can see when they detected the IgG binding as well as neutralizing antibodies, unbelievable great data. When they checked even the New England Journal of Medicine said if it is even the S antigen will be soluble part or attached, the same antigenicity were observed, and they compared, you can see the first and the second, and then they looked at the side effects here, the pain at the injection site, we all experienced that, and then the systemic symptoms that are marked after the second dose, the fever, the fatigue, the chills, lymphadenopathy, and this they well documented for the 2 types, Moderna and Pfizer. And you can see compared the 2, those are the convalescent serum. You can see the immunogenicity for the S binding and the the antibody levels. Of course, those are elderly gentlemen and women, when you grow old and you compare it between young individuals to a little bit older, of course, you can see the immune senses are decreased. Adverse events in more than 50% of the participants, systemic after the second dose, local as expected pain, redness, swelling, systemic fever, fatigue, and chills. What they said, they tried that on 40,000 individuals and they came up with 95% efficacy rate because 170 positive cases, 8 in the vaccine group, the rest in the placebo, and only 10 cases are severe, one of them in the vaccine group. The good thing is that, will one dose be enough? If you take one and you get scared, you're not going to get one. This result was published recently when they checked only 50 vaccinee, and you look at here what happened. They said first it's 82% of the first dose, 82% effective, but the post hoc analysis means data after everything has done showed the first dose will protect 52%. So you expect with the other vaccines, if you take one dose, you're not going to be protected compared to this one. You're not going to be protected as much, but you have to take the full dosage. How about the Moderna? Moderna has the same thing. Moderna is the one that is synthesized by the here in Boston, Massachusetts, MIT technology, and they are done in a lot of Africa, and of course will be in Israel and will be everywhere, and they are promised of 1 billion dose. I don't think that everything will be here in the States, and who knows who's going to get it next. But Moderna is the second one that is produced against the whole S antigen. Pfizer is against only the RBD. Moderna said the same thing. They tried it on 30,000. They had efficacy of 94%, 11 severe, none in the vaccinated, more or less the same. They found, as I told you, those cases, and then secondary analysis, more cases appeared, of course, but still the vaccine efficacy stayed at 95%. Side effects of the vaccine, as you've seen, anaphylaxis. This as of the CDC report a couple of days ago. 21 cases of the vaccinated they started the vaccine mid-December till the end of December. 21 cases that can be expressed as 11 per 1 million. Flu is 1.3 per 1 million, so it's 10 times the flu. 71% occurred within 15 minutes. When you take the vaccine, wait for 15 minutes. And the 17 had history of allergies. And there are still reporting close to 4,000 adverse events, 170 under review, 86 deemed non-anaphylactic but allergic, and still under analysis. And everything is evolving every single day. Like this morning, Science Magazine was talking about the durability of the neutralizing antibodies. As of today, the Pfizer trial, 4 developed Bell's palsy. Developed not right away, 3, 9, 37. And this expected, this is the Pfizer BioNTech, the German company. 3 in the vaccine group, 1 in the placebo. The FDA said that it is the likelihood that this is a normal occurrence in the general population, not vaccine related. 1 had shoulder injury from the injection, 1 had paroxysmal ventricular tachycardia, and 1 had right axillary lymphadenopathy and right leg paresthesias. They claimed that this is related to the polyethylene glycol. You know, polyethylene glycol PEG is present in most of the preparations that you use for colonoscopy. L-asparaginase is a form of it that you use in treatment of leukemias. So you can develop anaphylaxis to PEG. There are other ingredients like those different names. This is the lipid part that includes the messenger RNA, the sequence. Actually, the RNA is sequencing technology in the computer. So there are so many compounds there, additives. Is the anaphylaxis, unfortunately, the CDC will still, I have here like collaboration with the pharmacy, and we're going to see what are we going to do for those patients. So the polyethylene glycol was never used in vaccines, but used in medications. Found in many drugs, occasional anaphylaxis, rash can happen, high blood pressure, tachycardia, shortness of breath. Then unfortunately, we don't have the answer to it yet. How about the subunit vaccines that the last one I'm going to talk about? Use part of the vaccine, no live components. those are used in so many vaccines before. Hepatitis B vaccine, for example, the recombinant one. Epitopes, less likelihood of reactions, but they do not produce a good CD8, the killer. Memory is doubtful, and difficulty to determine which one you're going to take. Are you going to take all of them? Those are the subunit vaccines that they are going to be available. It is the most common platform. Why? They just took the protein, give it to the cell. Hey, immune cell, deal with it. Novavax, GSK, Sanofi, Dynavax, very reputable names in vaccines. Primarily inducers of CD4. Most of them, they use the S protein and they use adjuvant, and sometimes here the part of the Novavax that they use glyco nanoparticles. The word the nanoparticle doesn't mean a chip. It is not electronic stuff. Nano is a small one, and you use glycoprotein, you use lipid. This one, they use glycoprotein. Messenger RNA, they use lipid. Genetically engineered means sequenced in the computer. They put the pieces of the amino acids together of the spike protein, and they use it. So it's really very good. Novavax had very good studies. Still, the results are, the phase 3 is not back yet. Those are the only 83 individuals. And when they published the study in the New England Journal of Medicine on 131, you can see the response compared to the convalescent. You're not expecting it to be like the messenger RNA that was the robust next generation vaccine, but they have very good response compared to this. There is another one also, this virus-like particle, that they use the shape of the virus and they use so many proteins. Is it a good idea? Yes, it's really good idea. They use all of them because if somebody evades, they cannot evade your immune system. Canada is about to license the Medicago, which is genetically engineered, and this company is a plant-based company. They used it in tobacco leaves, and they get, like they said, it's quite safe. It's a kind of virus-like particle combinant with glycoprotein, with designed in a very simple way. So which way to go? Unfortunately, I cannot advise like one and over the other, but what I'm quite positive that please, vaccine is the only way out of this epidemic, and I hope you can all stay safe and make your own decision, and I hope that will benefit. Stay safe. Thank you.
Thank you so much, Professor Dr. Sana. We are used to the very, very illustrative and medical talks and extensive explanation in the vaccines. This is the first time I had heard a very detailed medical explanation for all the vaccines, how they are manufactured, the phases of the vaccine, and how to use them. Thank you so much.
More than welcome.
At last, I would like to thank all the lectures, all the...
دكتورة منى
أنا عارفة في أسئلة.
Questions, a lot of questions.
لا أنا بس ياسمين هي اللي هتقول questions. والله يا إيمان مش ناسية خالص. أنا بس عاوزة أشكركم يعني. I want to thank so much all the lecturers in this webinar. The webinar is more than excellent and very illustrative and very valuable in our practice. I would like to thank all the residents, the assistant lecturers, and the lecturers and the professors working at our university. Dr. Yasmin will continue with you for the questions you would like to ask. Okay, تفضلي ياسمين. Dr. Yasmin.
Thank you, Professor Mona, for such a great webinar. Thank you, dear professors, for a highly scientific webinar. Everybody actually is thanking you on the chat. They want the lectures and they are asking about the availability of the lectures. I think they will be available on Facebook page. Yes, Dr. Iman, I think, yes?
Yes, it will be available. It will be available.
So I will start the questions.
في سايت
نعم
عايزين تسجيل الويبينار في سايت
هيبقى افيلابل كله على الفيسبوك وهنعمله كمان كله.
Thank you so much. اتفضلي ياسمين.
I will start the questions to Professor Sana. I know it's getting late in the US. It's getting very late.
No, it's the opposite. It's still midday.
It's early?
It's,
okay.
Yeah, I had to leave work early today. It's midday today. It's noon.
So we're having a continuous questions. If I got COVID, do I take the vaccine? Do I have to wait 90 days post-infection?
This is the question that the CDC left it for us. They say that 90 days is the window that possibly you're going to be protected. Am I overwhelming the immune system with another dose of the vaccine when you already have neutralizing antibodies? Do they recommend using serology to detect? No. You can wait. The word you can wait and you can take. So they left it for my opinion, the risk actually in the first 3 months is not that much, because the first reported case early was after 5.7 months. So first 3 months, no. You want to wait a little? Yes, I will be cautious in triggering my immune system that much. I will wait for 3 months.
Okay.
My personal opinion, but no data.
Thank you.
We left it for
Thank
us.
you. Yes, thank you, dear Professor. Professor Iman, a lot of questions about the ivermectin, the age, the accepted age, the dose, and do we give it to children with contact to COVID positive cases or not? Please clarify this for us, because it's about 10 questions, the ivermectin.
Yes. زي ما as we have told in the lecture, ivermectin is for some guidelines or some researchers, it's a magic medication. But actually, according to CDC and WHO, it is not yet confirmed to be used either for prophylaxis or in treatment. Those who agree to use ivermectin, they only accepted age or weight for ivermectin is 35 kilograms. Before this, less than this, it's only clinical trials. No documented data at all for ivermectin. The only data is available is for children above 35 kilograms as regarding their weight. Below this, it is just clinical trials. As we have told, the dose is 0.2 milligram per kg, but still its role in prophylaxis in high-risk patients is not yet confirmed. But I should announce here that our Ministry of Health is putting ivermectin as a part of therapeutic management, the confirmed cases of COVID by special protocol. This special protocol including day 1, day 3, or day 4, and day 7. This is in our Ministry of Health, but this is for adult and as therapeutic only. For children,
how long
no.
in children?
No, it is not documented in children. It's only just trials, but they are putting different protocol according to the indication. For example, if they are giving for high-risk patients, different from this for those patients or on contact of a case, or those patients who had mild case and they are being managed at home. So for every one of these, there are special protocol. But again, there is no documented protocol. And again, CDC and WHO did not approve it to be used nowadays. Still, it is a matter of controversy.
Thank you, Dr. إيمان.
ياسمين، بس احب ازود حاجه الدكتوره ايمان قالته. الو،
اتفضلي يا فندم.
انا بس الايفرمكتين ده قريت عنه يعني شويه، وانا خدته me and 10 of my family no side effect whatsoever. وبعدين I asked the dermatologist إن كانوا بيدوه في التشيلدرن ولا لا، قالوا احنا بنديه treatment of scabies، وساعات في ناس بيدوها فور الديدان كمان. فالدوز of 0.2 ملغ is safe، بس اعتقد التشيلدرن اوريدي الكورونا ما بتجيلهمش جامده زي الكبار. بس if it happened ان حد جاله كورونا جامده، المفروض يعني نبتدي نديه لو الليفر فانكشنز بتاعته كويسه، لان هو الكومنت اللي انا سمعته وقريت عليه ان لو حد عنده فيروس سي better ان هو يعمل ليفر فانكشنز قبل ما ياخده. وبعدين
they are asking about الكونتاكت يا دكتوره منى، يعني لو في طفل في البيت وفي كوفيد بوزيتيف في البيت، they are asking to give it or not to give it.
as far as I know it is safe، لكن ان في حاجه study اتعملت I don't know.
Yes, not evidence based.
يعني yet. انا رايي لو هي حاجه حتى لو 10-20% هتبروتكت الدكتورز and nurses ياخدوه كبروفيلاكسس، لان دي هتبقى حاجه كويسه جدا. Thank you.
Thank you, dear professor.
So Yasmin, there is a question for you actually. Yes, question for you. When
yes.
staff with COVID positive allowed to go back to work?
Yes. In the first wave الحقيقة we were PCR based testing. كان ال healthcare professionals they go to work back after the PCR being negative. In the second wave, no. We wait 10 days from the start of symptoms, then they should return to work. But this is the policy now. We don't test everybody. We just, if there are symptoms, 10 days isolation, then they return to work. There's a question for Professor Mervet. Why we are not starting steroids and antiviral with moderate cases?
Okay. Thank you, Yasmin. Actually لو احنا هنحب نجرب اي حاجة في الدنيا لمرض جديد وغير معروف ملامحه وحدوده، كل واحد ممكن يجرب. بس يعني احنا بنتكلم من منطلق scientifically and academically. لازم نevaluate ال interventions اللي هنعمله من منطلق هو evidence based ولا لا. For the time being اللي اتعمل الستاتيز اللي طلعت علشان تعمل prescription للميديكيشنز الافيلابل كلها زي الستيرويدز والرامديسيفير etc. approved اليوز بتاع الديكساميثازون الستيرويدز يعني والانتي فايرال in the form of remdesivir in the moderate cases, but the subgroup which present the best result and outcome هم الجروب اللي كانوا محتاجين أكسجين ومش high flow oxygen. ده based on a large mega trial اتعملت على 20,000 بني آدم عندهم كورونا. طلعوا بيها من النتائج دي لما استخدموها في المايلد كيسز ما كانتش جايبه نتيجه. يعني احنا بنسمع على هيكتيك دوزز من الستيرويدز وفورمز غريبه من الستيرويدز بتستخدم، بس لما اتطبقت واتعملت ريسيرش على عدد كبير من الحالات معدي الافات بار سي تي محترمه كانت النتائج ان هو ينفع يستخدم وهيجيب نتائج كويسه في السب جروب اوف بيشنتس اللي هم بالسلكشن كرايتيريا بعينها دي او الانكلوجن كرايتيريا بعينها دي. غير كده النتائج ما كانتش up to a good outcome ولا قللت الديوريشن اوف ريكفري ولا قللت الادميشنز ولا حاجه.
Okay, thank you, Professor Mervet. Another question to Professor Sana from Professor Tariq Hamid. On the vaccine, the virus has an effect on coagulation. Are the vaccines tested its effect on coagulation?
No, not on coagulation. And even when they said the special groups that need to be vaccinated or to avoid vaccination, they left the leukemia and the lymphomas and all the malignancy, autoimmune disorders. They recommended using the vaccine. We're talking about, of course, the non-living vaccines. And even the transplant patients, they are allowed, provided that they take low dose immunosuppressants. If you take 5 milligram prednisone, for example, it's allowed to take the vaccine. It's not going to suppress the immunity. And all the transplant units, all the kidney transplants, we have here a lot. So coagulation in particular, I don't think so. And are they given to specific sick groups? As I told you, they are still analyzing the data. For example, the HIV, which is even immune messed up patient, they are still given. I don't think that vaccines they have a side effect on coagulopathy.
Okay, so Dr. Torre is asking also, primary endpoint, do you think its logic and safety is enough?
Primary, that's a good question. I'm showing a trend. Don't understand me. The trials that I just explained, phase 1 and phase 2, and we don't have the final analysis. And if I tell you, you've seen those graphs, by the way, the bigger ones, they are done on 196 patients, 144 patients, 86 patients, and I'm giving statistics like, wow, 90. I'm waiting on the final data. The vaccine issue is evolving every day. Final data on the 30,000 arm and 30,000 arm, and then after marketing, but those are preliminary data. Does this mean that it's not, we're talking about safety? Efficacy, I cannot say, because maybe when I showed you after the first dose, the immunity started to wane at 119 days. Are they effective when you challenge them with a pseudovirus, you know what I mean? Pseudovirus, you get the serum and they put a virus outside and you see the neutralizing effect. Neutralizing meaning what? Opsonization, coagulation, killing of the virus, not just binding, meaning engulfing and killing. Is it going to last? The neutralizing antibody, the effective neutralizing antibody will last for how long? How much of it? I don't know. No answers, unfortunately.
Okay, thank you, dear Professor. Professor Hanan? Professor Hanan is with us?
لا she is not here.
Okay. Professor Iman, when radiological findings disappear from the CT or the X-rays, when it is expected?
This is a very important question. Actually, we are following up the patient clinically and through the pulse oximetry and oxygenation rather than radiologically. We all know that sometimes the clinical improvement occur even before full radiological improvement. So please, no need to repeat the patient CT in order to be sure that he is improving. Depend upon the clinical data of the patient and level of oxygenation and general condition. You are going only to repeat the CT for follow-up only if the patient is not improving. But an interesting observation had been recently observed actually in some of the patients got what is called as post-COVID lung fibrosis. Actually, it didn't happen in a pediatric age group. It happened in adult actually. But who can tell? We can observe this later on. But no need to repeat the CT of the patient searching for the follow-up, just the clinical improvement only of the patient, because it's expected these changes to disappear within 2 to 3 weeks.
Okay, thank you, Professor Iman. Another quick question. CRP is high. How high? What is the cutoff?
Actually, I mentioned about this CRB in follow-up of in category of the patients which have been passed to the post-COVID syndrome, which is lung haulers. Comparing between the patient who didn't get this complication and those who get it, we find that the patient who had high CRB, but actually most of the studies did not mention a certain number to tell that those patients are going to have post-COVID. All what they are advising that with very high CRB, please be very cautious if you discharge this case to follow up their CRB and not to rapid taper the steroids. وهنا برضه I want to stress steroids is the main line of treatment for post-COVID syndrome. So it's advised that those patients should be on omega-3 and very small doses of steroid to minimize the lung hauler or post-COVID syndrome.
Thank you, Dr. Iman. Another question for a lot of questions for Professor Sanaa to highlight on from Dr. Ghada Saleh and Dr. Ganagla Shaheen. Do we vaccinate our hematology and immune-compromised children? Do we vaccinate pregnant women?
No, pregnant if they already had taken it no before without knowledge. No, they are not included in the group yet. Okay. As I told you, malignancy, they are still nothing had been in the group. I know for sure the transplant patients, I can check exactly, but I hematologic patients, yes. Malignancy, no yet.
And if the patient is on steroids?
5 milligrams is immunosuppressive dose, no. Any immune suppressant, it's not going to work. 5 milligrams, okay. As I said, prednisone is allowed. If 20 milligrams, no, they are not going to benefit. They are not going to.
Okay. Thank you, Dr. Sanaa. Professor Iman, is there any data about long COVID in children?
About?
Long COVID.
Lung? You mean
long COVID post? Yes.
COVID? Yes.
Long.
Yes. This is the long COVID. Yes. This is the bad news that this the sequelae is not only affecting adults. Nowadays, it has been recorded in children through the revision of the review literature. Actually, children starting from 10 years, maybe because this is the age which the children can express what happened for them. So they noticed that they are confused. They have lack of concentration, they have some memory problems, and they have some impairment of their style of life. They don't want to share in activities, and still this is actually happened. So children, in spite of being assumed that they have mild attacks of COVID, they are going to be exposed to the lung huller. And as I told, lung huller can occur for the patients who have been hospitalized, or those who have very mild symptoms did not need hospitalization.
I think, dear professor, we need to screen our patients for this, our 150 patients for this, yes. Okay, another question for Professor Sana. Which one do you prefer? If you had the choice, which vaccine would you take?
The virus-like particles or the protein vaccines. That's my, I took them, the messenger, the new vaccine, because now you cannot take it, because I see patients that they come to me with simply sinus drainage, and then I suspect the COVID, then it turned to be COVID without any, really scary. It's a scary situation. So I'm taking the messenger as a new one till the final results, but the protein vaccines are like, they have very good, like, you know, history. I like it. I like the protein vaccines. Inactivated, all the type of vaccines, that the ones that will be available in Egypt, as I said, inactivated is an old technique and had been used a lot. And without the vaccines, you would have seen cholera, you would have seen smallpox, and you would have seen polio. I don't think vaccination had made really a safer world and longevity for people to live longer, healthy lifestyle. So that's my.
So Professor Ihab Hakim was asking this question: do we take the Chinese vaccine or no, or wait for other vaccines?
You have to no. If you wait, here it is. When you, as a physician, you have also, when I give a vaccine, you know, here we have to make, when I give a vaccine, you have to sign a consent. And when I give even the flu vaccine, I tell them, Guillain-Barré, 1 in a million, paralysis. They have to, not because you defend yourself, you don't act defensive medicine, but people should be informed of the complications. So you tell them, these are the studies. What is my preference is to take. What I've done, I'm preaching what I've done. I've taken it. Is it a safe vaccine? As I said, there are risks up to transverse myelitis. That's kind of scary, which is Guillain-Barré or transverse myelitis. And then the facial ones, the scary thing, the interesting thing in San Diego and La Jolla, they said those guys that had facial paralysis was related to people had fillers a couple of weeks ago. So all cosmetic preparations, if you use fillers, then don't use messenger RNA. Then you have to tell them what is the safest, what is the best, you choose for them, you help them choose.
Thank you, Professor Sana. Professor Mervet, what are the causes of sudden death in COVID, and what are the causes of hypoxemia?
We encountered some patients, unfortunately, who developed severe hypoxia due to development of acute respiratory distress syndrome, and they pass because of failure to recover from the hypoxia. Sometimes needs high settings on the ventilator, and these are few patients in our patients who passed due to acute lung injury and ARDS. But the majority who died, actually, they have a concomitant comorbid condition, malignancy, exacerbation of rheumatological disease, multi-system inflammatory disorder, and multi-organ involvement, kidney disease or respiratory failure. I don't recall another patients who died by a sudden death directly due to COVID.
Okay, thank you, Dr. Mervet. Professor Iman, if high D-dimer in outpatient cases, and we meet this a lot.
Yes.
High D-dimer in outpatient, do you advise anticoagulation or aspirin? And there was another question, does aspirin cause Rey syndrome in these patients or not?
It is not recorded actually that the aspirin causes Rey syndrome recently, or to be related to our virus. Actually, it is not recorded in the literature. I revised this. Actually, we have great problem with D-dimer, great problem, because sometimes some patients came to the emergency room with nothing. It's just mild fever, they have no symptoms, but we are facing very high D-dimer. You know, our
Yes.
rule is that we are not giving anticoagulant if the D-dimer, except if the D-dimer is above double normal. For example, if our lab, the normal is 0.5, so it's only if it's exceeding 1. And actually, we are giving prophylactic doses of anticoagulants, not the therapeutic doses, unless it is very high, it's exceeding 2.5 to 3, or if the patient has thrombotic tendency. This is the rule. But the problem that I'm facing, and you, my dear colleague, face, that some patients are not having any severe illness to explain an increase in the D-dimer. You know, COVID-19 is not the only reason for increasing D-dimer. Okay, they have many other reasons. So if we get a patient like this, actually what I am doing actually is that if the patient has no other reasons for increasing D-dimer, I'm just waiting and I repeat the D-dimer after 2 to 3 days, but I am keeping an eye on the patient. Giving anticoagulation, the injection, it should be inside the hospital actually. We cannot give anticoagulation outside the hospital except in very limited indications. The use of oral anticoagulant, actually all the rules are children above 12 years. We don't have enough experience for children below 12 years to give the oral anticoagulant such as the Lerto or others. So if the patient is completely normal or stable condition and he has such unexplained D-dimer, I'm just supporting the patient, keep in touch with the patient, and then I'm going to follow up the patient after 3 or 4 days with the D-dimer again.
So we have another, we have a comment from Professor Dr. Alia. Could be thanking you all for the talks. Actually, we thank her for the great support she's always giving us, for the great cardiology team. Thank you all for the knowledge, the science, the effort, and the dedication that you show of us. You are always giving us a role model, and we just go after your steps. Thank you, Professor Alia. And she's asking about the personal opinion about the ivermectin.
Again, this difficult question about ivermectin. I want to tell you something. I took ivermectin, actually. But because I am always in contact with all of the case around me, being a pulmonologist, all are COVID-19 with respiratory affection. But if we are going to speak scientifically, there is no confirmed protocol, my dear Professor Alia. No confirmed protocol. I even revised this, my dear Professor Sana, about if any of the hospitals in USA are using it, and she told they are not using. And I am telling you that when I revised some literature, I found that they are taking their opinion supported by Egyptian studies. I think still we are in need to do some studies or randomized controlled trials in our hospital to know the efficacy of this medication in all levels, whether therapeutic or prophylactic. But still, we don't have actually a final answer for this, if it is very beneficial or not.
So this is an open question. Do you think there's a role for serology in diagnosing COVID?
Yes, I like these questions actually. You know, Yasmin,
yes, I know.
Actually, no role of serology in diagnosing or infection or reinfection by COVID, or to be sure that you are immune. No role of serology at all. This is according to CDC and WHO. They canceled the dependence of this serology on taking any decisions. The only indications, to be fair, is those patients with MESI, because I want to have a clue that what happened for them now is related to the COVID before, especially if the patient is not remembering what happened to him. So the only indication is MESI cases. Like, otherwise, it have no magic role as we were thinking before.
I just want to add a point. We are all afraid of COVID-19. يعني مرض غريب مخيف، مش عارفين، شايفين mortalities، بس في بعض الأحيان بحس إن إحنا بن over care. يعني الأوت patients مش اللي هم ما عندهمش أي severe ولا moderate illness، I prefer not to repeat labs, not to do labs, not to do D-dimers, not to image them, as long as they are compensated and no even moderate severe illness. And so we can give them any oral anticoagulant or any medications or even aspirin or any anticoagulant at home. The story begins when we are admitting the patients. And we need to go through all these trials by ourselves, whether ivermectin is good or bad, whether oxygen is good or bad, whether dexamethasone is good or bad. I think we have to cooperate all, all the sections.
Yes, it's
in the
still a new
department
virus. It's a
to
one-year-old
study.
virus. It's a one-year-old virus.
The new or
There's a
the
lot to
old
know.
one.
Okay, thank you, Dr. Mervet. Dr. Sana, a question من Professor Al-Adawi. What is the strain used in manufacturing the vaccine and how are they sure it covers the new strains?
Strain in which one you mean? The mRNA, and they are not a strain. They are kind of amino acid sequence to the S protein. Just
Yes.
not a strain. A strain for the inactivated vaccine. They for China, they actually, as I said, even the method of inactivation, which is, as I said, the beta propionolactate, I did not find it in their published literature. The problem with China is that they don't publish a lot, and when they publish, the publications are not quite clear yet. So I don't know the strain. I don't know the circulating strain, but most likely the Wuhan or like whatever Beijing, they have two. They said that there are 3 Chinese factories working there. I don't know. To answer this, I don't know the strain. I don't know the strain.
Thank you, Dr. Sana. A question for Professor Iman. Colchicine has an anti-inflammatory condition. Some studies showed the good effect in COVID and in cytokine storm. Do they have a role in pediatrics?
Actually, colchicine is also is not included in any of the guidelines of the CDC or WHO. Actually, only individual guidelines or individual hospital experience have used colchicine as an anti-inflammatory medication in some of the advanced cases, but it is not being trialed in children. We don't have any randomized control trial about using of the colchicine in pediatric age group. This is according to my information. Maybe Professor Sana, if you can add anything about using colchicine in your center?
No, nothing. No.
No.
We don't use except FDA approved stuff. No. And nobody will ever do something on his own.
Yes. Is Actemra helpful in children?
It depends. Like it is, of course, IL-6 you do first, you check cytokines. It depends on the situation. Yes, it is. It is. It's used. We've used it. Remember, we've used it in one patient.
Yes,
we did.
one patient, one or two patients.
We did. One indicated.
We used it in two patients.
Again, it's case by case discussion, to use it or not.
Of course.
A question by Professor Amal Faramawi to Professor Sana. If the infection can occur after, if a reinfection can occur in 3 months or after 3 months, how the vaccine is suspected to cause long-term immunity?
I'll tell you why. When I explained the first infection, it depends in order for you to mount a good immune memory. You have to activate the adaptive immune system. If your innate immune system, your natural killer, is super active, and that the innate starts within infection right away, minutes and hours. The adaptive takes days. If you get rid of the infection early, you don't have a good memory. That means the T4 cell did not help the B cell with to make immunoglobulins, and did not turn into B memory cells. What is needed from the vaccine, when they check the curves that I put and the graphs that I put, they check both, and this is required by the by the serology, by the CDC and NIH, you have to check cellular and humoral immunity at the same time. So the vaccines are double checked. And when they don't get enough immunity, that's why you add adjuvant to stimulate the T cell. So you make sure that the vaccine will succeed in giving you long-term immunity. Infection can or cannot, depending on how fast you cleared the virus from your circulation.
Your system, yes. Thank you, Professor Sana. Professor Iman, if the patient is clinically well after COVID infection, but still has D-dimer high, serum ferritin high, do you discharge or give low molecular weight heparin?
I want to stress about actually serum ferritin. We have a problem with this marker because we observed that some patients, especially with comorbidities, have persistent high serum ferritin. But this is not a reason to keep the patient in the hospital. Actually, if the patient is clinically stable and most of his lab investigations going down, we can release the patient with a cautious follow-up after 2 or 3 days. Giving anticoagulant at home, of course, as you all know, is risky. Most of the guidelines did not agree at all to give anticoagulant at home. We were obliged to do this for a minority of cases, especially those patients which have comorbid condition, rheumatological cases, where we know that they have thrombotic tendency. So we were obliged to give them these anticoagulants at home, but this is not the rule. So if the patient have persistent D-dimer and general condition is good, we can release him unless he has an underlying comorbid condition. If he has underlying comorbid condition, we are not allowing him to go whatsoever.
Okay, another question, Professor Iman, about the indication of steroids in post-COVID syndrome and the dose and the duration of giving this steroid in post-COVID, because a lot of question about this.
Yes. Actually, the post-COVID or long hair actually is a new era or new idea. We don't have enough information. As I told, there are many reasons to explain what happened for the patient for 10% of cases. As I told, it is maybe due to hyperactivity of the immune response, or this is due to resistance of the virus still inside the host, or this is abnormal immune response. We don't know. Even to some extent, they told it has nothing to do with the virus. It has something to do with the bad experience the patient faced. But as I told you, 55% of those patients, we find some vascular changes in their brain when MRI have been done for them. So the advice in these cases, and this is that to give the patient steroids when they are released from the hospital, if they have severe COVID necessitating admission to pediatric ward or to ICU, and especially if they have high CRB, and especially also if they have severe or categorized as severe or life-threatening, all what we need is to taper steroid very slowly and giving omega-3. But if the patient released from the hospital and after few weeks they start to have these manifestations, which are being confused, being not concentrating, being had amnesia or something like this, still this is under trial. They are giving omega-3 for sure, but giving steroids in what doses, it is not agreed anywhere. Still, this is a very new field, a new era. We don't know actually what is the suitable dose for those patients. So it's a matter of try. It's not only for steroid and omega-3, they are giving also a long list of medications and neuropsychiatric medications, I mean, but still there is no final format for the doses or the amount of steroid which should be given to the patient. So maybe in the next webinar, inshallah, we'll get new answers
about
for
the post-COVID.
Yes, yes.
Yes, thank you, Dr. Iman. Dr. Vervet, this question is for you. Do we need CT imaging for patients coming with GI symptoms?
GIT symptoms.
Yes.
Sometimes we
As
have
part of the workup.
We have overlapping symptoms between chest and GI manifestations. But actually, what we have been experiencing is that the pulmonary infiltrates is starting to appear late in the onset of the disease, after 3 to 5 days. Sometimes patients were asymptomatic regarding chest symptoms, but have some ground glass appearance in the CT. And this doesn't guide us to escalate or de-escalate management in their treatment unless it is beyond 50% of pulmonary infiltrates. Sometimes there we can use, if the patient have 50% affection with hypoxia and there is oxygen needs, we will go to the algorithm of dexamethasone with remdesivir. But for routine use of CT imaging for the chest in patient presenting with GI manifestation, it's not routine. It's not routine even for patients with mild respiratory symptoms. And Dr. Iman is better than me to tell the scenarios, the different clinical scenarios for choosing CT.
Okay, thank you, Professor Mervat. The American Academy of Radiology or Radiodiagnosis actually deny the need of any CT for the patient who are symptomless at all. CT is not part of the routine investigation for those patients who have no respiratory symptoms at all. If he has GIT symptoms only, it is not an indication to do CT to diagnose pulmonary involvement. Just clinically follow up the case. If the patient starts to be symptomatic, and as my dear colleague, Professor Mervat, if your decision of management is going to be changed, so please, you can do CT only in this condition, if the patient become symptom or have respiratory symptom. This is actually a very important question because I think 90% of the Egyptian people, adult and pediatric, have been exposed
abuse of
to
resources and unnecessary radiological exposure. Yes, yes, thank you. Okay, we have a question for Professor Sana from Professor Hamad Al-Khayyat. How to check efficacy of the vaccine? It needs post-license survey studies.
That's why they are still they're following stage 3 for the, as I said, they are just releasing the data from the first group, first phase 1 and 2. From the vaccinated, no, but for phase 3 that they had 60,000, then they are gonna tell us, and based on that, of course, we can apply to the vaccinated group. You cannot check on the vaccinated unless they are in the trial.
Okay.
The question is for them here, whoever was in the placebo group, and those the unfortunate guys that some of them got the disease, will they keep taking them or they will give them the option to take the vaccine? Unfortunately, they are going to give them the option to take the vaccine, and it's done.
Ethically,
yes. So they are going to compare the results. Yes.
Okay. There's a question to professors about the benefits of plasma, the convalescent plasma for COVID in pediatrics. I believe we didn't have an experience in that, but if you can add on this.
For us in our pediatric hospital, we don't have
in pediatrics,
any.
No, in adult only, yes. So, question.
Even in adults, the use of convalescent plasma only.
Studies only.
Yes. Dr. Mervat, fever in infants, when to suspect COVID, please.
Dr. Mervat, افتحي الميكروفون, please. You are mute.
Fever should be the first symptom in 100% of our patients of acute COVID and MESI having fever. We don't have a certain level, a certain cutoff fever, and even some patients may be afebrile or having a low-grade fever. But fever is one of the signs and one of the symptoms and signs of COVID. And we should suspect in the patient the COVID, especially in our pandemic. If he is in close contact or household contact, the patients with COVID, family members coming from abroad, any exposure, we will consider this patient is having COVID unless there is another determined etiology for such fever. And we should go according to our resources. If there is other symptoms suggestive, it will raise the awareness and raise the suspicion of being a COVID. And if it is feasible to do the PCR testing, it will be fine. To consider patients في كوفيد ولا لا. وده برضو مش عشان نبدا حاجه معينه as long as the symptoms mild، علشان اذا كان في high risk patients around ولا هو high risk patient we should take into consideration.
Okay, Professor Iman, regarding children with genetic hypercoagulability who are already on anticoagulants, is it important to increase the anticoagulant dose in case of infection or prophylaxis against thrombosis?
Yes, because sometimes those patients will be on a small dose or prophylactic dose. If they got COVID infection, I think it's better to change them to the higher regimen from prophylactic dose to the therapeutic dose, guided by their lab investigations, including T-dimer, PT, and PTT. So those patients actually are at risk. So we should monitor them very closely and should shift them to therapeutic anticoagulation, and better to be at hospital, because you know one of our mortality, it was one of the patients with polyarteritis nodosa, those patients which have underlying thrombotic tendency. So those patients, it's better to be hospitalized and to monitor their therapeutic level of anticoagulation according to their lab results and according to their other investigations.
Okay, last question. There's a lot of questions, and questions are coming in. I believe that we can continue to midnight, but the last question is about the lab frequency time in hospitalized patients. When to do follow-up for the lab, the markers in hospitalized patients.
This from you, Yasmin. This question is from you.
I'm always concerned about resources. I want the scientific backup.
I haven't been reading a certain frequency for repeating a lab in the inpatient or the hospitalized patient, but we are really should be aware that don't do labs for the outpatient if he is not sick, if he is good, and if the patient is inside the hospital. Think about if your decision will be changed about certain lab, just go and do it, and you don't have to repeat in a certain frequency. For example, when we have met patients with bleeding tendencies, and we are thinking to continue or to discontinue anticoagulant therapy, we went through testing the bleeding profile and the platelet count for this patient. When we are trying to take a decision to start Actemra or not, we went to searching for the level of interleukin 6. We should have a question to be answered based on such labs. If we are if we are about to discharge a patient and we need just the labs to see a trend of improvement, we will do the lab to discharge the patient. And I don't believe in a certain frequency after the first wave coming and we are going to the second wave. This is my opinion. I think Dr. Sana and Dr. Iman may have another, I don't know, but this is my opinion.
Especially, I need to know the frequency of the ferritin and the D-dimer, because they are done actually every 48 hours.
I have, before we end this, Dr. Sami Bahna wanted to say something. Dr. Sami is the eminent allergist, immunologist, professor of pediatrics, as well as allergy immunology, Louisiana State University. He is the program director of the Allergy Immunology Department in Louisiana State University, and he was the vice president, at one time the president of the American College of Allergy, Asthma, Immunology. He wanted to say something to you, and he is enjoying the discussion. So is it possible to open the mic for him? Dr. Sami Bahna?
It's an honor to have you, Professor.
He raised his hand.
باشمهندس سامح، ممكن نفتح the mic for
Dr. Sami Bahna.
باشمهندس
معاك يا فندم.
دكتور ممكن تفتح مايك for دكتور سامي بهنا بليز؟
حالا يا فندم.
I don't have enough to say about Dr. Bahna. If you just Google the name or the I learned everything I learned in the States, like come from him. Dedication, work, attitude, care, scientific thinking. He is my mentor and he's my friend, and he is really, the words are not enough to say anything about him. So I hope.
هو معانا يا فندم بس يفتح بس المايك.
Thank you very much, Sana. Do you hear me now?
Yes.
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 All right. Thank you for your kind compliments, Sana. And thank you for informing me and inviting me to attend this superb, and I really mean it. You know my personality. I don't give free compliments. No. You deserved, you earned it. I was planning to attend part of it, but I really did not leave 1 minute from the program. All the speakers were superb. You're at the cutting edge of information. I benefit from all of you. And I'm proud that you as colleagues in Egypt organized this webinar. And it seemed that many were listening to it. And I'm glad that you will put the whole program online or on Facebook to be available for those who could not attend, or they can go back to it. It was a real pleasure for me to spend those couple of hours with you. Just it was pleasant to see that I'm hearing good information. The design of the slides and illustrations were great. The method of delivery, I was very impressed by it. And thank you again.
Thanks to you, Dr. Sami.
Thank you.
Our pleasure,
Thank
really
you,
an honor for you to attend. I really
It's an
wanted
honor.
to show you the wonderful group in Egypt. They are really, they are competing for excellence, and all of them, it's real, you will not imagine the effort and the time and the heart behind every single thing that is being done. Unfortunately, was not shown to the whole world, so I don't know how to show it, like from the other part of the world here, like I want everybody to know how is it going there, and all the blessings and prayers for him. And thank you very much for attending. It's my pleasure, Dr. Sami. كل سنة حضرتك طيب.
Thank you for inviting me. It is good that I saw you. I don't think I met any of you because usually I come to the allergy immunology meetings.
You meet only Ilham and Zainab most of the time, but I don't know whether
Zainab, Kamal and others. Yes. So it's wonderful. Do that again and again.
Okay, I will inform you. This is not the first time. This is actually our third or fourth one. Third or fourth one. It has been almost like, and the previous ones we had. If you honor us, then we probably would love to have time for us.
You are great. You are absolutely at the cutting edge of information.
Thank you very much.
And you are in the front line there. I hear about the tragedy, about the diagnosis and treatment, and I have relatives who became sick there. They find great difficulty in getting beds, even in the expensive private hospitals.
Yes.
And you are a wonderful army against this terrible pandemic.
Yes.
They are doing with very little resources relative, even us in the United States.
Yes.
That is, the hospitals are full. I recently was speaking to a colleague, a professor at Harvard University, where that they have multiple great hospitals in Boston. And she told me that once the patient in the hospital speaks and can walk, will discharge so that you can use the bed for people who are sick out. So I'm not...
Dr. Sami, Dr. Mona Ganzouri is the head of the department, and she is really there with the residents as well as the director, Dr. Yasmin. She is although she has a lot of responsibilities, but you will never imagine with the residents, with the students, with all the responsibilities in person, not being afraid from any infection, or she got the infection herself and with her family, and nobody, they are volunteering every single bit of their time to to the like best of the country and the best of the university.
Well,
University.
Is a good leader and good team. By the way, I took my second dose of the Pfizer vaccine.
You did? Okay, congratulations.
Yes,
So you were with it, okay?
The first dose did not do any side effects.
The second did fever?
Second dose, because I took it in the evening at the end of my day. I felt yesterday lousy, but today I'm much better.
I had a friend who took it and he said his axillary lymph nodes got enlarged and his tonsils as if he's a child, and he felt miserable with 104 temperature, stayed overnight in a miserable situation. I said, okay, good for you. Immune system is working.
This is nothing.
Yeah.
Well, I'm glad. By the way, the question, I was tempted to answer the question of what is the best vaccine? The best vaccine is the available vaccine.
Okay.
Yeah.
I'm not going to choose, whereas there is only one. Whatever comes first, I'm going to take it.
This is a good point.
Egypt is bad. I understand the culture. People are still not putting masks, and they are in crowded places, in the buses or in the metros. It is not healthy. They need the vaccine. All right, God bless all of you. Be courage, and you are the real army.
Thank you. Our pleasure and honor.
Thank you. It's an honor, dear Professor.
Cannot hear you, Dr. Mona.
So, Dr. Mona, we cannot hear you.
Cannot hear you.
Professor Mona. Dr. Mona.
Cannot hear you.
No. دكتور منى مش سامعين حضرتك.
I cannot hear you.
Okay. خلاص, we'll wrap it up.
Tell her we cannot hear you.
هي سامعة. احنا مش سامعين. هي عارفة قالت لي.
Okay.
Okay. So, shall I wrap it up, Professor Mona? Okay.
Okay.
So, we'll wrap it up. Thank you, dear professors, for the input. It was great being amongst you. Thank you. I thank all the attendees for their attendance and for the questions. Last thing to say, be safe. God bless you all and have a great night. Thank you, Professor Sami, for attending this, and we were honored to have you amongst us. Thank you for your encouraging words. Thank you all.
Thank you. Have a great night.